Good morning, everyone. I'm Kushbu, PhD scholar. With me, Suchitra, PV Associate. Welcome you all to the second day of the conference. I hope you all are excited for another day fulfilled with the insightful discussion, networking opportunities, and new learning. Yesterday, we delved into so many interesting topics. It was truly inspiring to see so many brilliant minds coming together to show their expertise and ideas. Let's make today even more enriching and impactful than the last. So, without further delay, let's get started with the first session of the day Symposium on Antimicrobial Resistance. For this, I would like to invite our respectable chairperson on the stage, Professor Dr. S.K. Sai sir, ex-Teen Academy, IGIMS Patna, member of Bihar Technical Service Center, Bihar, Patna. Our second chairperson is Professor Dr. Namrata Kumari ma'am, Professor and Head, Department of Microbiology, IGIMS Patna. She's coming. Now, our next chairperson is Professor Dr. Manish Shankar sir, Professor and Head, Department of Respiratory Medicine, IGIMS Patna. Please come on the stage, sir. I request our respectable chairperson kindly take over and commence the session.
Good morning, everybody. Uh, I hope that everybody has finished his breakfast and be ready because I am thankful to the organizer for putting this topic because this topic is a well-known topic and every day we are facing it. So the antimicrobial resistance is probably from I am a microbiologist from our forum also. We are dealing with that on all over India basis, and we have met the different forum for that is antimicrobial resistance. The pharmacology, actually, it is the जिसको कहते हैं जननी drug का. So they are also looking at this business. So I am very happy, and I am seeing the program in which I am seeing the people who are going to speak. They are really a stalwarts. And I hope that you will able to get a brief about this microbial resistance by their talk. And without further any delay, I will first uh, invite Professor Dr. Asutosh Biswas. I hope that everybody in this hall must be knowing him because he's an international figure and he was as our director, vice chancellor here, and now it is he's at the Bhubaneswar as executive director. So, Professor Asutosh Biswas, may I request you to take the lead?
Very good morning to all of you, respected chairpersons and the dignitaries here, participants. I'm really very happy to be here today, and it's a great honor for me to take part in this conference. It's given me 15-20 minutes to talk about the antimicrobial stewardship program, which is very important. I think we have been talking. I'm involved in this infectious disease business for many, many years. In AIMS Delhi, I was there for more than about 30 years to develop the Department of Infectious Disease AIMS Delhi. It took me almost more than 25 years to develop that. And we started first time in India, DM in infectious disease in Delhi, under the medicine department. So that is the first AIMS we started. And then 3 years and 6 years DM in ID. This is going on. And there are after that many AIMS and many other institutions have started developing and creating the Department of Infectious Disease. And also I have created Department of Infectious Disease in AIMS Bhubaneswar after joining there. So we are working on this field because it's exclusively, I remember maybe around about 20, 30 years, I was very much into this field. I was trying best, but our departmental head and other professors said, no, the infectious disease department cannot be, is not required. Because everybody is, prescribing antibiotic. and looking infection, surgery, cardiology, neurology, everybody, all physicians, they know to write antibiotics. So you don't need a separate division or department for infectious disease and exclusive this program. So finally because I was trained in infectious disease in various countries in UK, US, and also Singapore. I was there for a antimicrobial stewardship program, antimicrobial resistance, this all activity in Singapore. There is a hospital which is 100 years old, infectious disease, exclusively Institute of Infectious Disease and Epidemiology in Singapore, 100 years old. You can imagine their program is very robust. So as there, I went to learn what they are doing and how the program is, how they are managing the infectious disease. So I'm lucky to be trained in that. So to share it very quickly, I'll go into this, the very exclusive ASP, antimicrobial stewardship program, what it is. It is a commitment with some activities targeting to reduce the resistance, antimicrobial resistance, and to minimize the unintended adverse event associated with the use of the drugs, antibiotic. So this is the only the aim of this. So how we are going to do, what we are doing, what the government of India and every states, health is a state subject, how the states and the institution, how they are involved, and what are the policies here, what really, how much we are serious about this. So this is a matter of very much concerned, what we are going to, how we are going to address these issues. I'll go quickly that the institute should have a policy. So how robust this policy is, what are the structures of this policy, and who are the players, who are the stakeholders of this institute, the department and the institute, the infection control committee, and that is H hospital infection control, and DIC is the departmental infection control committee. So HICC, DICC, each and every hospital, there is very structured program all over the country, and the government and the research program, ICMR, they are trying their best for last 10 years or 15 years. We have been trying hard to implement this. So it is a challenge, and where are the gaps? How we should really improve to implement this policy ASP. And it is not, I'm going to take it slightly away from the hospital to the community. And this is a antimicrobial stewardship program in the community. We have to go out of the hospital settings and in the community, and every one of the citizen, each and every, we are responsible for this. So how then this emergence of this, uh, the resistant pathogens, and what is the impact of this? So we are going to discuss about that. So it is a one health. We cannot just think for the only hospital setting. We cannot it is not only human health that we are thinking about. We cannot be selfish to think about only our health. The COVID-19 has proven that this is not only human, COVID-19 is a zoonotic disease. Everybody knows that. It's spillover from the animal to the human being. So if you ignore the animal and environmental health, you will be wiped away. So it is one health you have to think. So how to integrate this human health and animal health and then environmental health. Integration is a very important issue. So how we are going to do that? So this is the issues that we are going to discuss about the antibiotic resistance. This is one, because how it is going to, and it is not only the hospital that healthcare workers responsible for this transmission of resistant pathogens from one person to another. It is the environment and then the animal, how it is, because these are exposed. The antibiotic is used not only the human against the infection, human infection, but against the animal and also the environmental various the agricultural issues, food processing, and your dairy, food product and all. So we have to address these issues also, and how we are going to do that. So this is what after the hospital infections and all, people are going back to the community. And not only the person is carrying and taking this pathogens to the community, is the other way also, the hospital waste management. This is going into क्या हुआ? Timing ठीक है, okay. अब 20 हो गया, okay, okay time है. So now this hospital waste management, and the people going from here, they are going into the community, and now people are infected in the community and infected inside the hospital. So hospital acquired infections and then community acquired infections. And what are the proportion incidence of resistant organisms in the community? So if you talk about the community acquired pneumonia, this is a very common. And how much these are resistant pathogens in the community. So how we are going to prescribe, how we are going to address this treatment part, what antibiotic, that how many antibiotics we are going to start in the beginning as an empirical therapy. So then, and there are, is going into the community, and then agricultural food, and then also antibiotic is really we are whatever you call is a misuse, abuse, or your, and what is the impact? Impact is that we know everyone that how much it is rational. Is everyone is competent to prescribe the antibiotic? Everybody is knowledgeable to prescribe antibiotic? And if not, then what is happening? In India, is the situation is known to everyone. If you go to any counter, you can buy and you can take the antibiotic from the counter and you can use it. So this is the scenario. Now, I think 50%, 40 to 50% of people are going directly from the community. They go to shop and ask for, I am having this, and this pharmacist, they are prescribing and giving the drug. Because if the patient goes to the doctor, he will charge for 200, 500 rupees for the fees, and then with the prescription he will go to shop, and the medicine he will buy suppose 50 rupees or 100 rupees, and he gave 200 or 500 rupees to the fees to the doctor. Now he thinks कि डायरेक्टली अगर मैं फार्मासिस्ट के पास आ जाता तो 50 रुपया में हो जाता काम, डॉक्टर को 200-400 रुपया फीस देना पड़ा. So they think probably this is wastage fees and giving 50 रुपया दवाई के लिए मैं 200-400 रुपया फीस क्यों दूं? That is the concept. 50 to 70% of people, they think, अरे खांसी जुकाम है तो चलो दवाई ले लो काउंटर से, and they give a cocktail of so many medicines, and antibiotic is one. So we don't have much antibiotic now. Concern is the most important serious problem is that you see then from the 80 to 2000 we have only 63 new antibiotics that time. And started from 1940 this antibiotic, and it was a wonder drugs, saved millions of people. Now over the time, the many antibiotics were there, and from now 2000 and onwards we did not have much. Very few antibiotics are in the market, and there is not much in the pipeline also. That is a matter of concern, and growing with the emergence of this. So this is really a crisis and hidden crisis. So this is economic loss also. The people are buying it, and this is a huge economic and unnecessary use of antibiotic, abusing the antibiotic, misuse of antibiotic. So The ASP is designed to in the hospital as well as in the community. So hospital, you know what we are trying, every hospital I think we have been trying, and it's a teamwork to prevent this kind of infections. There are two things now very important. One is that I said I'm focusing a little bit more in the community because this is a very important issue. We are neglecting that part. ASP, antimicrobial resistant, we talk about the hospital setting, but we very rarely talk about the community part. The community is the how it is because the food industry, the agriculture industry is there is I think 50% they're playing role in this. So they are exposed and we are using this for this. You see, this is for growth and for also the business, the $1 million business, and what we are doing for this. And we are using this antibiotic very, very commonly. Almost all product in the market that you are getting and using the antibiotic in a low dose. And there are these very many countries, they are very strict. And developed country, the timeout period, the washout period of the antibiotic we are using for the animal, for growth and for the business, there should be a large dose of antibiotic has to be mentioned before it goes into the food process, food chain. They have to mention it, otherwise that food will not go into the food chain for marketing. Many countries are very strict. And the food, they have to show that yes, this is the last dose. And the sample has to be tested for residue of the antibiotic in that food. There should not be any residue. And that is how we are consuming and coming into our many foods that we are getting exposed. There are second issues. So the residue of the antibiotic is transferring from in the food chain, in the agricultural chain. So another issue is the resistant organisms. We are exposing these animals, and in the fecal material, these organisms are growing and they're resistant. And we are using the animal, this dung for manure and using in the agriculture field, and this is how it is transferred from one to another one. So organisms, the pathogen, multi-drug resistant organisms are also transferred. So two things, the residue of the antibiotic as well as the organisms are transferred into the community through the food chain. Everybody is eating. So even though you vegetarian and non-vegetarian, vegetarian also the food product and all manures and organisms are going through that. So what are the policy government is addressing this? Is there any regulations to control this? No. I don't see in India we are very much strict. We are checking the residue antibiotic in the food. I've never seen the certificate or any regulatory authority is certifying the residue washout period, last dose of the antibiotic given. This is required, but it has to be very much regulated into. So this each and every I think product almost we are facing this. So this has to be very clearly addressed at the government level. This is an important issue. So I have been raising this various forum to address how really we should be very strict, because developed country has made it and you cannot get any residue into this food. So this is how, and this is our habit. This is what we are doing. The hospital and the waste management is very important. So, see, we are throwing this. And this is contaminating the soil and the water. And for the hospital environment, this water is going into the community. And this water is used by the agriculture, animal, as well as for the drinking of the human being. So the antibiotic residue, if this is not addressed, this is a very common in the hospital environment. And these residues are transferred to the communities traveling, the residue, and exposed. The community is very much exposed and is not seen, it is hidden. We are not this. So this regulation, this is we are taking very carelessly, and this is one of the important. If we and this is outside the hospital, and if you go inside, then there are other many things, and we have been now. This is all this, and this is now people are going and directly buying medicine. This is who is going to address this issue? Government, the over the counter, the antibiotic. Which antibiotic should be available? Have you made the regulatory this is there any guideline, regulations, or this drug should not be available in the counter without prescriptions? Without this is nothing. No, till now it's not a very much. If we are not going to implement this 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 policy, we cannot control. And this is a very serious issues. So this is to now when we have many things are coming developed, manufactured, we are transporting, using, and what is the regulation for recycling? What is happening those after the product? Now, what happened? How these are all recycled? Waste management, there is no return, no policy. So, now if we talk about the inside the hospital, now we talk about outpatient stewardship program, inpatient stewardship program. Now, outpatient, I think prescription rate is very higher than inpatient one. Inpatient are serious, but a number of prescription in the outpatient, the doctors are prescribing much more, 20, 30 times more than the inpatient prescription. So what we are at is what we are doing for the outpatient stewardship program. That means what? Are you educating the healthcare workers? And how not only the prescription, in a healthcare setting, there are healthcare workers. What is their attitude? Are they educated? There are two ways. The people are coming from the community. They can expose, they can transmit the resistant organism to the healthcare workers. And at the same time, healthcare workers, they can transmit to these pathogens to the community, to the people coming to the OPD. So how we are addressing that? There should be strict policy in the outpatient for managing, and the doctors should be also educated. The policy should be there. What are the antibiotics should be prescribed if you are diagnosing community-acquired pneumonia, suppose CAP or UTI? So what I am supposed to prescribe? Is there any community antibiogram? Antibiotic and the testing and the resistant, do you have any report in the community? Some places it is a geographical, some areas are very high resistant to the pathogens and some area probably not. It's a research constant setting. The most early developing countries are facing this problem, and the million people dying every year in I think developing countries are the most affected countries. So we do not have policy in different. So we need to, I think there should be a paradigm shift of the concept of this one. It's not confined. We have been talking about the ASP in the hospital setting, but you have to come out, and still we are fighting to implement this ASP program into the hospital setting. There are many components into it, many programs. It's a continuous process. So outpatient department, what is the ASP? What program? What stakeholder? The management group, the infection control management group, how frequently they are giving training to the doctor, then resident. Resident is prescribing. They are sitting in the OPD, and are they taught about what antibiotic really you are supposed to prescribe? And this is the policy of the hospital policy. If you diagnose this, you are supposed to prescribe this medicine, this antibiotic. You cannot, if you go for a higher, then expert or the consultant should prescribe the high-end antibiotics. Do you have this policy? No. You have to make this. You have to come up with this policy. You have to have this courage to come up. Yes, see, this is what our infection control and prescription habit, prescription policy of this hospital. This is what we have. So every institution should have this without wasting time. So how we are going to do that? And who are the player, you know better. So you have to come up. If the patient is admitted, we we are prescribing the neurologist. If the meningitis, they do their own, they select their own antibiotic, and then cardiologist, the infection, the surgical, the wound management. So there is nothing much a policy. We have to come up with the policy. We have to come up with. We have to educate them. Just this is what the policy, so that we can reduce this all associated this antibiotic associated complications and the mortality, morbidity and the cost. So it's a very challenging. It's a very challenging. So these are all the factors why it is challenging to implement a stewardship program. So you have to, if you start doing, probably now we have been talking, there is nothing this all, if I show the slide, I have been showing slides, many things, I thought of not to project any slides, but we have to understand this. It is not a Einstein theory or magic that we cannot do it. Policy, if there's some group of people and the hospital authority should give a message, you must do, and within this time, and regularly you have to meet, and this is what we have to do. And so basically there are 5 R's: the reduction, refinement, replacement, review, and responsibility. Somebody has to take responsibility. And if you are using the antibiotic, now just I will give one example. In that hospital in Singapore, so it's a committee including the ID, pharmacist and microbiologist and a group. 24/7 you have to be alert. There's a, if I am sending the culture suppose on Saturday and Sunday is off, then Monday we'll see the culture, and then probably we are going to change the antibiotic depending on the organisms, directed the pathogens. It's not. You must. And what is the mechanism? Suppose if antibiotic, if the organisms are cultured, immediately it has to be communicated in a separate channel. It's not just a report or a hard copy or anything. There should be a separate channel of fast track. A network has to be developed. And that has to go to some department, some who is the head and the SP committee or infection control committee, immediately to alarm them to change the medicine, and this is what your culture report is, without wasting time. Otherwise, we are giving empirical and we are not sure what we are treating. So the hospital setting, in inpatient, there are many components. I am not going into that each and every component of that. There are 6, 7 steps. The ICMR and WH has already, we have been doing that, is laid down clearly how we are going to implement this and all very clear. The Government of India has also published this Infection Control Committee, ASP program, how it should be implemented and all that. What are the key aspects, key roles. So, and what strategies, this is what you can see how we can prevent the infection into the hospital, in a hospital setting or as well as in community. These are all steps, and core element are the hospital leadership has to be there, and then accountability. Somebody should be accountable, and then the pharmacy or the physician's expert, ID expert has to be there, and what actions we are doing after that. this implementation and then regulation, very frequently monitoring and tracking also. This is very important. For last 6 months, 1 year, you have to monitor antibiotic prescription, antibiotic side effect, mortality, morbidity, and then also this tracking and how is this is a inpatient. Can we implement this as a outpatient and also in the community? In the community, this is not the same that hospital setting that we are having the policy. There is separate other ways to minimize it because we are dealing with the serious infections, and there is slightly modified one. And then the diagnosis, the duration, dose, proper drug, choice of the drug, duration, and proper time, on time. So to these are all fundamental things. And then if you have started, then de-escalation and this discontinuation of the drug is not that you go for 5 days or maybe 7 days. कितना दिन देना है, 5 दिन देना है, 3 दिन देना है, 10 दिन देना है, कोई गाइडलाइन है? नहीं नहीं, चलो अभी 7 दिन दे दो, और चलो ये थोड़ा 10 दिन दे दो, थोड़ा सेफ साइड में 12 दिन दे दो, 15 दिन दे दो. So this is how it is going on. Yeah, so, and if we have a team, if we have the regulatory authority inside the hospital, probably that could be a robust program to start to continue the proper use, rational use of the antibiotic. And so, uh, these are all important things. Dose is adequate. The overdose or maybe dose is not more or less. And de-escalation is a very important. How is not that 15 days you give the same dose. You have to think when to de-escalate and when, how. These are all the policy. And then sometimes no, it's not required, and then still we are giving. The prophylaxis is also important. Sometimes we are giving 20-30%. The patient is admitted in the hospital. They are not infected, don't require antibiotic, but we are giving. As soon as the patient is admitted for prophylaxis to prevent hospital-acquired infections, we are giving antibiotic. This is not an ideal policy. This is not a good policy. So then IV to oral switch over and time out. So TDM, therapeutic drug monitoring, also to be, I think, there in the hospital, and cycling, antibiotic cycling, that mismatch. Sometimes it is the pathogen is something else, and you are giving some other antibiotic. Yeah, so these are all mismatching. Also, is not targeted to the organisms. And antibiogram is a very important. Hospital should have their antibiogram. The microbiologists, they should come up with every month or every 2-3 months, they should come up, or 6 monthly antibiogram they should generate in the hospital to disseminate to the doctors. Knowledge, they should be educated, this is what organism and this is what the resistant is. So that a prescription habit to be monitored and controlled. And this is what our AIMS Bhubaneswar, the antibiogram, this is what recently, and I have made this all to do, and this is going on. Infection Control Committee in Bhubaneswar, they're doing well, but we have to improve further. And this all, most of the time, syndromic approach. Doctors, they think, okay, I'll give this medicine, that medicine, or maybe pushed by the pharmacy or maybe pharmaceutical industry-driven prescriptions. So there are many issues into it. So this habit syndromic approach is a good for the rational, so for empirical therapy, but that should be uh, uh, very rational and depending on hospital to hospital and from different geographic situations is not the same that Bhubaneswar and then Patna will be the same antibiograph and same practice of the antibiotic. It should not be. So this is a teamwork to reduce this antimicrobial resistance. It's a very serious. So many is every player has to really work hard to reduce this, and these are the steps how we are going to principle of rational antibiotic use, how we are going to, those who are prescribing, those who are treating, and what principle they should follow. The hospital should come up with this. I'm not going one by one steps. And then this program, these are all, I think, the structural, this process that AMSP, antimicrobial stewardship program. So how these are all, this is little bit more detail, and time is not permitting to me to go through the detail all this. So just I am showing this surveillance, continuous surveillance should be there, and looking for the infection related mortality, how much. So do you have a data every 2-3 months or 6 months or yearly, do you have a data, the infection related death, how much, which infections are there. Hospital should come up with that, the mortality and the related issues, and what are the major issues related to antibiotics, is so many things, and important driver for antibiotic prescribing in the community as well as in the hospital setting. So there are practice. So what practice in the hospital, infection control practices, this all strategies we have to follow. And care bundle approach, this is one of the concept, how we are going to care, and it is a challenging. Thank you very much. Thank you for your kind patience. Thank you everyone.
Thank you, sir, for your. I do not think that there should be any question because he is crystal clear that what is the Government of India program and what it is. What little my knowledge deserve that he was slightly was not bold enough to tell that what is the government commitment. I think that the main question is that if the political commitment is there, because he told indirectly that in the last 10 years, there is no antibiotic available. In last 10 years, there is no, or only the antibiotic next generations, they are molecules they are prescribing. That what will happen, that if the 10 years there is no antibiotic, there are another 10 years, how you are going to do it. So, okay, the Government of India program is there, but how to control it? There is a two major point in my view what he has indicated, that Government of India already gives the guidelines, then there should be no antibiotic should be given from the drug shop without any prescription. And even the guidelines by the Government of India that which antibiotic they have categorized first degree, second degree, broad spectrum antibiotic and their things. So even the hospitals, the hospital program, antibiotic control program, which a team he has already described. In my view, the two part, one is the Government of India, the political commitment should there, that drug should be stopped from the drug store. And the second part is the community program for which the drugs are used for the animals. That should be stopped. Then only the other commitment, what he has told, that will formulate. I think that I thank you very much, Dr. Biswas.
Thing in it, sir. Good morning, sir. Actually, sir has rightly said that anti-biogram should be there. Our hospital, our microbiology department is also issuing anti-biograms annually. We are providing it annually, and we are doing these things under NCDC. There are two surveillance systems in the country. Rather, third one also has been very recently, it has also been proposed, or it has also been started. One is under NCDC, that is surveillance program, and another is ICMR. So we are working under NCDC and we are giving antibiogram to the hospital annually. Actually, it is not possible monthly or 2 monthly or 3 monthly, because the data is very less. So a big data is needed to make a antibiogram. Sir's presentation was excellent and he has covered all the aspects of AMR. Thank you, sir.
The organizer that to facilitate him. And then the next speaker will be the topic will be the choice of appropriate microbials. This preparation of hospital antibiotic policy, technical guidance for a step-by-step workflow that will be given by the Dr. Saibal Das.
Professor Dr. S.K. Sai sir to felicitate our speaker, Professor Dr. Ashutosh Viswas sir. Thank you, sir. Come on the stage.
He is MBBS and he has done MD from Christian Medical College, Vellore in pharmacology. He is DM in clinical pharmacology from JIPMER, Puducherry. And currently he is working as scientist D in ICMR, Center for Aging and Mental Health, Kolkata. Presently, he is working with the health system and policy team on improving use of medicines in the Department of Global Public Health, Karolinska Institute, Stockholm, Sweden. This team addresses the global threat of antibiotic resistance by conducting research, training, and policy dialogues. He has contributed in developing the hospital antibiotic policy of JIPMER Puducherry, and he has 95 publications in several peer-reviewed journals. And right now he is going to talk on preparation of hospital antibiotic policy, technical guidance for step-by-step workflow. Welcome.
Thank you so much, Madam, for the kind introduction. Respected Chairperson and respected dignitaries, very good morning. Firstly, I would like to thank the organizers, especially Hitesh sir, Lalit sir, Sukalan sir, and everyone for giving me this wonderful opportunity to talk in front of you regarding the preparation of a hospital antibiotic policy and technical guidance for a step-by-step workflow. So in the next half an hour or so, we will quickly see what is the inappropriate antibiotic usage and its implications. The majority has been already described by Ashutosh sir, and one of the major ways to combat is the formulation of an hospital antibiotic policy. What are the technical steps in the process of formulation of such a policy, and also a bit about the antimicrobial stewardship program. So this is a very common case which we often come across in our day-to-day clinical activities and in the literature, that this is any random patient and might be happening in a very common practice to every one of us, that a patient with an intra-abdominal infection or maybe any other infection without any Clostridium difficile was unnecessarily prescribed double anaerobic coverage with piperacillin, tazobactam and metronidazole when he was hospitalized. And a series of failures actually resulted in continuation of this to double anaerobic coverage during the entire treatment course. This is a very common scenario which we often come across, and we often follow a Swiss cheese model in the hospitals for doing surveillance and for doing a checking of inappropriate antibiotic so that there is least chance of medication related harms. And when we see that the case of our particular patient, the patient when the patient was admitted, piperacillin, tazobactam plus metronidazole was ordered, were advised for an intra-abdominal infection, and the best thing that yes, sorry, just 1 second, yes, yeah. Yes, yes. Then the patient was given an order which was not verified, and it percolated through a Swiss cheese model, and finally when the patient was discharged, again a double anaerobic coverage was given. So understanding about the factors which influence an antibiotic use, there is a structure which is already in place. There is practical implications, and there is a lot of system networks which implies lot of hospital related algorithms, policies, and there is a multifactorial reasons why and when an antibiotic is prescribed and when it is wrongly prescribed. So the hospital antibiotic usage process, we will focus on this because we will be talking about the formulation of an hospital antibiotic policy. So we need to understand this. So from the ordering till the hospital discharge, there are multiple stakeholders who are involved, which starts from the prescriber, who is the basic clinician who is actually prescribing the antibiotic at the point of care, and then it has to undergo subsequent further steps through the pharmacist, through the nurse, and then when the patient is getting discharge, then also again the role of doctor comes and also the role of pharmacist comes. So these entire stakeholders who are in this entire process are involved in cross checking the entire prescription when the patient is being prescribed antibiotics. This is an algorithm which is followed in the NHS hospital antibacterial use process. This is seems to be complicated, but it has a certain multiple degrees of checklist that I will not go into the very detail, but just to say that this is the on the left hand corner top is the start point, and when the patient arrives in the medical ward, based on a syndromic approach, the patient is being reviewed by doctors from different hierarchies, and based on the objective blood level parameters, the antibiotic is prescribed or not prescribed or later deprescribed. And when the patient goes till discharge, there are multiple check levels which are involved. Even after all these, there are chances of inappropriate antibiotic usage on the first place, and continuation of the usage till even discharged. So inappropriate antibiotic usage in the hospitals, there are factors. Already Ashutosh has spoken, I will not go much details into it. There is a perceived there are patient related factors for giving a patient satisfaction, or for advancing age, and patient actually tend to get antibiotics and recover faster. They have certain kind of perception. There is some empiric judgment. There is due to outbreak of disease, and there are promotional activities, etc., etc., which often lead to inappropriate use of antibiotics. And factors guiding antibiotic selection, if you say, we understand this conformism, that everyone is prescribing antibiotics, so why not the other doctor will also prescribe antibiotics. So this sense of a conformism comes into play. And there are there are factors which also depends or influence the selection of an antibiotic, which have patient related factors, pharmacokinetic dynamics of a particular antibiotic, the resistant pattern, etc. So what is the result of this? There is emergence of resistance and hospital cross infections. There is antibiotic pressure and leads to cross infection, which adversely affects the healthcare associated infection, the cost of treatment, hospital stay, etc. And of course, the origin of multi-resistant nosocomial organisms, like the notorious escape group of organisms, which often cause a lot of disaster and cause mortality. So strategies against antimicrobial resistant microorganisms in the hospitals. So we are focusing today now on the hospitals. So to develop a system which recognize the antimicrobial usage trend, and to develop a policy which will rapidly detect and report resistant microorganisms and ensure prompt treatment, and to assure increased adherence to the basic infection control policies, to incorporate the detection, prevention, and control of AMR as an inherent institutional policy, and to develop a plan for identifying, transferring, and discharging and readmitting patients with resistant infections, and to establish policy and practice for rational antimicrobial use. These entire series of activities are required to take as a measure to combat antimicrobial resistant organisms. And these are the same as the strategy goals: to optimize the duration of treatment, optimize antimicrobial prophylaxis, and develop and implement an antibiotic policy, monitor and provide feedback regarding AMR, and improve antimicrobial prescribing by educational and administrative means. So with this background, a lot of hospitals, including IGMS and various other hospitals, have a lot of combat forces or the activities which are being taken, and in the forms of multiple committees, like we have hospital infection control committee, hospital outbreak management process, infection control process, cleaning, disinfection, sterilization process, biomedical waste management, occupational health and safety. And one of the crucial step is antimicrobial policy and antimicrobial stewardship. So if you see this Venn diagram, if you want to prevent the spread of antimicrobial resistance and reduce inappropriate use of antibiotics, it requires surveillance, antimicrobial policies, and antibiotic management programs. So today and now we will be focusing on this antibiotic policy. So starting with the process for the development of an antibiotic policy. So this is the structural framework, and if we see that there is an hospital, when there is an hospital associated infection control committee, there is a surveillance of antimicrobial resistance and antibiotic consumption. So these are interlinked with the formation of an cumulative antibiogram from the hospital as well as from the community, because community antibiograms are important. We will also see in the subsequent slides. And this from this data which is generated from the history of the registry of the hospital infection over a certain period of time, and amalgamating with the surveillance data, and which is also coupled with the antibiogram data, this can lead to the formation of the antibiotic policy, which will eventually lead to the formation or the formulation of the STGs, and which overall constitute the antimicrobial stewardship program. So what is an antibiotic policy and what is its primary aim is to minimize the morbidity and mortality due to antimicrobial resistance and preserve the effectiveness of the antimicrobial agents. So this policy is, what are the factors determining the policy or based on which a policy is made? Based on the spectrum of the antibiotic activity, the PKPD of each antimicrobials, the adverse effects, the potential to select or cause resistance, the cost, and for special groups of patients like the elderly or pregnant women or pediatric and the special population. So what are the key elements of an hospital antibiotic policy? So the key elements should include the policy regarding prophylactic and empiric therapy. It should be having a multidisciplinary group. I will show you the step-by-step process of formation of the policy. Adaptation from the pre-existing guidelines or to suit the local needs, or because a lot of hospitals have a robust antibiotic policy that can be adapted based on the local settings. Based on the systematic review of the local AST data and surveillance data, and recommended antibiotics should be effective against pathogens present in the locality. The posology of these particular antibiotics regarding the dosage route and duration, identification of the research gaps, process of audit and policy review by independent experts, and evaluation. So there is one key attribute is that most guidelines should be hybrid of varying degree of evidence and expert opinion, because as I told that some of the policies can be adopted from the policies which are existing in other hospitals having a similar context, but not everything can be adopted, and it also depends on the expert guidance of the clinicians, microbiologists, or the clinical pharmacologists. The guidelines should not be excessive and should identify the evidence and research gap, and it should be a dynamic and has to be a flexible living document. So we will see how this antibiotic policy development cycle starts. It starts here on the right hand side of this bubble, and we will see what are the different steps involved. So the first step of formation or formulation of an hospital antibiotic policy is to make a multidisciplinary antibiotic team, which is usually 6 to 10 members, usually from infectious disease, internal medicine, surgery, pediatrics, clinical microbiology, pharmacology, of course, and from pharmacy. And they are given this task of formulating this policy as well as to revise it periodically. And they also have are given the responsibilities of deciding on antimicrobial dosage, treatment alterations, streamlining the therapy, discontinuation or de-escalation, use of restricted antimicrobials if particular antibiotic needs to be undertaken, therapeutic drug monitoring and based dosing, then use of specific antimicrobials and also dissemination of educational events. So this first step is the formation of an working group, which is a multidisciplinary team. The second step is when this team is formed and they sits together and forms a meeting. The second is to review the available antibiotic policies and evidences. so which can be obtained from the repositories of various hospitals. And of course this is a very context specific document, and because antimicrobial usage depends on community related factors and local factors based on local antibiogram plays an importance. So although the policy or certain parts can be adopted, but that also needs to be modified based on various parameters of antimicrobial policy which is available for that particular hospital and context which is concerned. Third is to draft the policy based on the available evidence. Now, when we say about drafting based on evidence, we mean that we have to undertake a systematic review of the scientific evidence to minimize the risk of bias, because there is a lot of literature which is available in the public domain, and when we try to synthesize the evidence, we need to do it systematically and objectively to minimize the bias. And when robust evidence is not there, I reiterate that the absence of evidence has to be supplemented with the expert guidance from the multidisciplinary expert team. And when we actually see the evidence of use of a particular antibiotic in a particular disease setting or particular disease which has been adapted from a different setting, but we want to adapt in our hospital setting, we need to objectively interpret the findings, and actually we have to grade the evidence. Suppose if we see the efficacy or the effectiveness of a particular antibiotic based on the literature from a similar contextual settings in other LMICs, when we don't have our data if absolutely likely from our country, we have to adapt from the literature or from other documents. In those cases, we have to actually qualify the evidence which is there and whether the evidence is robust enough and strong enough to get adopted. So for this, the grade approach for assessing the quality of a systematic review, like grading, recommendation, assessment, development, and evaluation, it can be useful to actually qualify the evidence. And when we try to adapt the evidence from other documents, we need to compare, and we need to understand both from the research question, that population intervention, comparator, and outcome, whether these are similar to what has been already there in the literature and based on what we are actually trying to adapt in our scenario. And based on the assessment of the quality of the evidence, we can classify these as a high quality, moderate, low, or very low quality. And based on that, we need to decide whether that needs to be adopted or needs to be upgraded. So when we say, when we want to qualify this evidence, we need to look in these 5 features which is there in the right hand side, factors to consider. The risk of bias in the original studies, whether the studies that were included or the literature which is actually has generated data, whether that contains studies having bad methodological quality or not. Then the imprecision, what is the level of confidence interval which is given, which shows the efficacy of a particular antibiotic, what is the precision range or the imprecision. Then inconsistency, whether multiple studies are showing the similar results or multiple studies are showing dissimilar results when we consider one particular antibiotic against one particular organism in a similar setting. And indirectness, this is very important, whether the population we have in our hand is similar to the population where the original study or the other evidence what is already published are similar or not, whether the organisms are similar or not, whether the antibiotic practice is similar or not. If these are not matching, then we cannot directly adopt. And of course, publication bias. Once we have gathered the evidence from the literature, and we also supplement it with the expert guidance from the team, the next is to ensure the key attribute that the policy should be simple, clear, clinically relevant, flexible, and applicable to day-to-day practice, and the recommendations should be very crystal clear and should guide for the selection, dosage, route of administration, duration of antibiotics, and what to do if a person has hypersensitivity, is having hypersensitivity to a particular antibiotic, and what to do for special populations, and also recommendations for prophylactic antibiotic use, especially like for surgeries and all. What are the policies to be taken it has to be written in a very crystal clear manner. The step 5 is the next step is to identify the evidence gap and the research priorities. So the policy group should identify the research evidence or the policy evidence which is lacking and areas for further research, which can include an evidence gap, which may include a knowledge gap, practical knowledge gap, methodology gap, a theoretical gap, or a population gap. The WHO document clearly mentions that if a hospital antibiotic policy can, including a team of multidisciplinary experts, if that can stimulate a community-based or a hospital-based epidemiological study to generate further evidence on antimicrobial susceptibility or antimicrogram, that is very good. That is, so not only the policy should get over in formulating one document, but also to identify the research gap and address that. The next step is the monitoring and review of the policy. So it says about identification or to identify the sample outcome measures for audit for both the process as well as the outcome of the policy. So the audit for the process of drafting the policy as well as for the outcome of the policy. Monitor and evaluate the quality of antibacterial prescription of right dosage and duration, and this policy should be reviewed by independent experts who are not a part of the team of the policy, who's the team forming the policy. And as we mentioned, that the policy is a living document. The next step is the dissemination of the policy, and the studies have clearly shown that why these guidelines, many hospitals do have antibacterial policy guidelines, but these are not widely implemented. So implementation factors come into play. Guidelines are not properly disseminated, and often the clinicians are unaware. Studies have clearly shown that clinicians are saying that we do not know the existence of any policy, even they are working in the same hospital. So dissemination is also one of the key attributes for successful implementation of a policy. And studies have shown what are the barriers to implement a particular policy. So barriers can be scientific, like it may lack the scientific validity, it may lack the representation of an important stakeholders, lack of familiarity with the guideline recommendations, lack of outcome expectancy, or can be also due to failure of the incorporation of the local opinion leaders or the cultural practices prevalent to endorse the guidelines. And studies have shown what is the facilitators. Facilitators for or adopting a particular policy is promoting ownership of the guidelines by involving potential users in the development. If we add more clinicians who are actively involved in the process of prescribing the antibiotics, that sense of ownership which comes and helps, and incorporation of guidelines into service contracts between the purchase and providers, and local adaptation of with the national guidelines. These are the facilitators to implement the policies. And there are some strategies which are given to promote rational antibiotic prescribing based on the policies, how to overcome these barriers. The next step for this entire exercise is the surveillance of antimicrobial resistance. So what surveillance helps and why it is important? Surveillance data helps to formulate, monitor, and identify the prevailing and emerging problem. And surveillance checklists are based on standards, reliable numerator, which is very, very important, because I will come to that in the next slides. Express resistance as incidence rate and participate in external quality assessment schemes. So WHO has a strong surveillance, that's WHO net, which is a very robust surveillance, but here we use that ICMR surveillance, and NCDC has also taken an initiative. So while evaluating a surveillance system, it is important to understand, does the system detect trend that signal changes in the occurrence of the disease? Does the system is robust enough to capture the change in the trend of antibiogram and antibacterial susceptibility? And does the system lead to improved clinical practice by healthcare providers who are the constituents of the system? So how the changing scenario with the ASTs is getting reflected in the prescribing policies, and who is being picked up by a surveillance system. And prediction of evolution of AMR, the behavior of antibacterial use and its dynamic relationship. We can do modeling studies, time series analysis to do this mathematical model to check antimicrobial resistance. And there is also a surveillance of antibacterial consumption. They should formulate the antibiotic policies and development of standard treatment guidelines. So just to talk a brief about the surveillance tools, which are very important. So we know that the WHO ATCC tool is there, and but studies have also shown that better guidance is obtained using cumulative antibiogram. And there are a lot of other matrices which are there apart from defined daily dose, like days of therapy, length of therapy per patient. There are a lot of ways in which we can actually define the antibacterial use consumption by the patients. Regarding cumulative antibiogram, Sarah has already spoken that cumulative antibiogram represents a report which summarizes the susceptibility over a defined period of time, and it helps to show the trends over a particular period of time. And this is also important because if we want to see that trend, we need to generate sufficient data to have the bulk to prepare the cumulative antibiogram. And that is why Madam said that it is not easy to prepare every monthly or 2 monthly. It needs a certain time to generate the voluminous data. So there is a CLSI recommendations on cumulative antibiograms, how to prepare it, how to potentially avoid misleading data, include species with more than 30 isolates, and if suppose one patient is undergoing multiple treatment, use the only first report so that it doesn't get duplicate, compile in statistical significance because it changes with the percentability of the susceptible isolates. And there are certain challenges in cumulative antibiogram also, because the variability in culture and susceptibility ordering, it varies based on hospital to hospitals based on the policies. So in particular setup, if the clinician is ordering more ASTs than in the other hospitals, there is a chance of a selection bias if more data is generated from that particular hospital. And the number of requests are less when compared for sensitive cases are less as compared to the resistant cases. So there is again a chance of bias that more resistant cases gets picked up in the cumulative antibiogram. Community antibiogram is important. We have learned this already, and how to develop it is a challenge, of course. Hospital versus national antibiotic policy. Now, this should be ideally be coherent with modifications based on the local adaptive needs. And if there is a wide variation from the national to hospital antibiotic policy, the desired purpose is actually defeated. And based on the hospital antibiotic policies and based on this antibiogram, the next step is to develop the standard treatment guidelines, which is important for the treatment of the cases, which the clinicians will use at that particular point in front of the patient. So ICMR also gives a standard treatment guidelines for taking syndromic approach for the common infectious diseases. And this also takes into this antibacterial stewardship, which process to assist, support, and clinicians with decisions regarding the dose selection and duration of the antibiotic. And we have gone through the principles of ASP. I am not going into the details. And regarding formation of a hospital antibiotic policies is also required to categorize the antibiotics based on the levels of antibiotics which can be prescribed based on the hierarchy of the doctors. Like almost similar thing, we have an award classification reserving certain antibiotics. First level can be prescribed by the relatively junior level doctors, and as it escalates, it requires the senior consultant signature, and this has to be audited. So these are the core elements of an antibiotic stewardship program where antibiotic hospital policy plays a very important role. And we understood there are a lot of challenges in implementing ASPs. There is lack of interdepartmental coordination, absence of a champion, and etc., etc. And I will skip this part, how to start an ASP in the hospital. To go very briefly about the month 1 and 2 should be the planning and the initial planning phase, and subsequently the implementation phase comes from the, so it takes around 6 months to 8 months to formulate the policy as well as the entire antibacterial stewardship program in a hospital. And there are sustainability measures also for an ASP initiatives. It includes community awareness, use of incentives, and it's a collective responsibility, and also availability of microbiology culture facility and universal antibiotic policy. And the presentation will be incomplete without finally going into this prescription audit process, which is also a part of an monitoring or surveillance process where routine studies are conducted, cross-sectional studies are conducted to audit the prescriptions which are being prescribed regarding the use of antibiotics in particular scenarios. And the World Health Organization has given a methodology for point prevalence survey for hospital usage in antibiotic usage in hospitals, and how this can be used, how exactly prescription audits can be done to support the policymakers and practitioners for antibiotic use, and to provide a
Sir,
standardized
sir,
tool for the
kindly,
hospitals.
sir, kindly
Yes, madam.
conclude it
Yes.
first.
So
Yes.
this is the last slide. That's impact of hospital antibiotic policy. Once we have developed a policy, how it can reduce the antimicrobial usage. This was a study which was done in CMC Velo. This blue part shows the development of a policy and how the use of antibiotics can be reduced after this. So, a hospital antibiotic policy can lead to containment of rising overall antibiotic use over a period of dissemination. So, with this, I conclude the presentation. Thank you for your patient listening. Sorry if I have exceeded the time.
Yes, it was an excellent presentation, rather. Uh, so, any speaker? Dr. Vikas Maharshi.
Rasi, yeah. And he is MBBS from UCMS New Delhi and MD Pharmacology from Lady Hardinge Medical College, New Delhi. And he also DM Clinical Pharmacology from AIMS New Delhi. And about his experiences, he was senior resident from Lady Hardinge Medical College and AIMS New Delhi. And he was scientist D in ICMR AIMS New Delhi Center for Rational Use of Drugs. He was assistant professor in GMC Barmer during 2019 to 2020, and he is right now assistant professor from AIMS in AIMS Devghar. And the topic he is going to discuss is really a difficult one: the choice of appropriate antimicrobials. We, for the clinicians also, it becomes a very difficult question: what antibiotic should we choose, because every microbials have got its own sensitivity, and it also depends on the comorbidity of the patients and the side effects. So over to Dr. Vikas Maharshi.
Thank you, sir. Thank you all, and I welcome all the dignitaries on the dais and off the dais, my seniors and colleagues, for discussion on the topic selection of appropriate antimicrobial agents for around next 20 to 25 minutes. So I will cover the topic under these heads. That can affect appropriate selection of antimicrobial agents. Then aware classification, that is access, watch and reserve classification of antimicrobial agents recommended by World Health Organization. And then two clinical cases based on the discussion just for sensitization purpose. So let's start with the importance of this topic. Why this topic is important here? Because whenever we talk about antimicrobial use, a single term that comes in our mind, definitely that words comes in our mind, and that is resistance, development of resistance. So the main reason for appropriate selection of antimicrobials is to prevent development of resistance. The study I quoted here assumes that if the antimicrobial resistance keep on spreading as it is spreading today, in that case, after 50 years, the more than 10 million mortalities will be recorded just because of antimicrobial resistance. And in that case, it is going to prove even deadlier than a malignancy. So that is the challenge that we are facing, and we have to prevent the development of resistance. Here I can show you few data from the latest GLASS report. GLASS is Global Antimicrobial Resistance and Use Surveillance System, that is GLASS. 2022 report, that is the latest report released by WHO. This report tells about the data, how much resistance we are facing towards multiple microorganisms. Like if we talk about bloodstream microorganisms, these are few common microorganisms: Acinetobacter, Escherichia coli, Klebsiella, Staphylococcus aureus. So let's, for example, in Acinetobacter, if we talk about resistance in Acinetobacter species, so around 50% of the Acinetobacter isolates are resistant to aminoglycoside antibiotics. And there are more than 70% of the isolates of Acinetobacter are found to be resistant to carbapenem antibiotics and so on. So these are few data just to show you here how much, what is the extent of antimicrobial resistance that we are facing currently. The urinary tract infection pathogens like E. coli, uh, the Klebsiella pneumoniae, like in E. coli third generation cephalosporins, almost uh, 35 to 40% of isolates of E. coli are resistant to third gen cephals. And the similar data is for fourth generation cephalosporins, and fluoroquinolones are relatively the E. coli is fluoroquinolones. E. coli is relatively less resistant to fluoroquinolones. Fine. And Klebsiella pneumoniae as compared to E. coli shows higher resistance rate. Likewise, these are for gastrointestinal infection like Salmonella or Shigella species. We can skip these details. So first is to prevent development of resistance. Next, obviously, to reduce the adverse effects, we have to cautiously select an antibiotic and to reduce the healthcare burden on the government as well as on the patients. Now next, we are going to discuss what are the various factors that govern appropriate use of antimicrobials. There are mainly three major factors that we can say. One could be host factors, another could be factors related to pathogen or etiological agent, and third, it could be related to drugs. So all that is required for selection of antimicrobial is just interplay between these three factors. Fine. Now, what are the various epidemiological factors that can affect selection of antimicrobials? So for that, we have to know few common terminologies like this is a chronology of a disease. Like first of all, infection onsets, then symptoms appear, then we may identify the name of pathogen, and then the disease will be resolved. So if we want to use antimicrobials before the onset of infection, that is known as primary prophylaxis. If we want to use antimicrobial agent after onset of infection but before appearance of manifestations, that is preemptive therapy. After appearance of symptoms but empirically, means pathogen is not known, what is the pathogen actually causing the disease. In that case, it is empiric therapy. If we know the name of the pathogen, we know which antimicrobials are going to be effective. So that is known as definitive therapy. And once the disease is resolved, manifestations are resolved, but eradication has not occurred. In that case, if we want to use antimicrobial, that is known as suppressive prophylaxis or secondary prophylaxis. So let's briefly discuss about the primary prophylaxis. As I told, in primary prophylaxis, we use antimicrobial agents before onset of infection. There could be some conditions where we have to use antibiotics even before the onset of infection, like in surgical prophylaxis. And in primary prophylaxis, the antimicrobial use is just based on a guess. Guess means it is based on most likely pathogen. What is the most likely pathogen? And based on that, we use antimicrobial agents. So the dictum here is whatever antimicrobial we use, it should be of spectrum as narrow as possible to prevent development of resistance. So examples of primary prophylaxis is surgical prophylaxis and prophylaxis against opportunistic infections in people living with HIV. Like in HIV patient, if the CD4 count is less than 200, in that case we have to use some other antibiotic. If CD4 count is less than 75, we have to use some other antibiotic. So CD4 count also determines the choice of antimicrobial in primary prophylaxis. In preemptive prophylaxis, like some individual has undergone stem cell transplantation. So the individual is at high risk to contract CMV infection. So by RT-PCR, we can know the levels of CMV So if there is low levels of CMV, might be the manifestations are not there. In that case, we can use antimicrobial to prevent disease manifestation. Next is empiric therapy. The most of the use of antimicrobials that we see in our society is because of empiric therapy. Means infection has occurred, manifestations are there, but we do not know exact nature of the pathogen. So that is empiric therapy. And the different thing in definitive therapy and empiric therapy is that in empiric therapy, the spectrum of antimicrobial that we use is, it is a relatively a wider spectrum. Relatively a wider spectrum. I am not saying broad spectrum, extended spectrum. Relatively, it should be wider spectrum because we are using antimicrobial just basis on the guess what could be the most likely pathogens, and we have to cover all of the most likely pathogens. So spectrum here is a relatively wider as compared to definitive therapy. And undoubtedly in definitive therapy, because we know the name of the pathogen, so here we also know what antimicrobial is effective and against which the microbe is resistant. So obviously our work is easy in this case. So here we use narrow spectrum antibiotic, as narrow as we should use. Fine. Next is secondary prophylaxis. Secondary prophylaxis, as I told, the manifestations of the disease might have resolved, but eradication has not taken place. Like in, if I talk about malaria, in cases of severe malaria, we use intravenous artesunate at least for 48 hours. So after 48 hours, it might be possible that manifestations of the disease has been resolved, the severe disease has come down, but still the malarial parasite is not eradicated from the body. So after 48 hours, or as soon as the patient starts accepting orally, we switch the IV therapy to oral artemisinin combination therapy. So this oral switching of this therapy is known as secondary prophylaxis. Next factor that may play a role in selection of antimicrobial agents is antibiotic susceptibility testing. This testing tells us two things. One, it tells what is the causative microorganism, and second thing, it tells us what is the sensitivity to which antimicrobial agent the causative agent is susceptible and to which it is resistant. And accordingly, we can select the antimicrobials. We can skip these graphs. I think they are not relevant for us. Okay. If we talk about host factors, age is an important consideration for choosing antimicrobials. Exclusion is also an important strategy. Exclusion is also a part of selection. Among the options available, if we can effectively exclude the poor options, then we are obviously left with the good options. So exclusion is also a part of selection. Like in pediatric population, we know the toxicity of chloramphenicol, sulfonamides, and tetracycline. So we should avoid using these antimicrobials in pediatric population, and in geriatric population, we should avoid aminoglycosides. Next, host factors are renal functions and hepatic functions. So the antimicrobials which are excreted through renal route and individual is having renal impairment or hepatic impairment, then we should use the antimicrobials that can be excreted through some alternate route. For example, in renally impaired patient, we can use cloxacillin, clindamycin, macrolide, metronidazole, and these antibiotics because they can easily be excreted through biliary route, and the same is true for these antibiotics. Next factors that determine the selection of appropriate antimicrobials are local factors. Local factors means the factors which are at the site of infection. At the site of infection, like presence of pus. The pus will hamper the entry or hamper the reach of the antimicrobial to the microbes, inside the microbes, and it will definitely reduce the efficacy of antimicrobials. In presence of foreign body. In foreign body, why is it a special case? because in foreign body, the microorganisms have high tendency to develop a biofilm. Biofilm is a covering around the microbial colony made up of exopolymer that hinders the entry of antimicrobial agent into the site. So until unless we remove the foreign body, it is very difficult to eradicate the infection. But in some of the cases, we may not remove the foreign body from the body, like in prosthetic implants, it has to be retained in the body. So in that case, we have to be cautiously use the antibiotic that can enter at the site of infection, or we can use combination of therapy as well. Hematoma, acidic pH, all of these factors reduce the efficacy of few selected antibiotics, and we have to keep them in mind while selecting an antibiotic. Presence of barriers, like if I give an example of prostatitis. If in bacterial prostatitis, most of the antimicrobials do not reach an adequate level in the prostate gland, in the prostatic ducts where the infection is occurring. So we have to be very cautious while selecting antimicrobials. Like fluoroquinolones are highly lipid soluble drugs. They can easily cross the capillary membranes. What is a peculiar feature regarding the prostate gland? The capillary membranes in the prostatic ducts, they do not have pores, and they do not have active transport system as compared in contrast to other capillary membranes. Fine. So here the antimicrobial agent has to rely on its passive diffusion only. So we should use antimicrobials that are highly lipid soluble and can easily cross the membrane, like fluoroquinolones. So fluoroquinolones are the first line agents for treatment of prostatitis specifically. Definitely allergy should be considered. Immune defense, it is not hard and fast, but as a general principle, if the patient is immunocompromised, we should use bactericidal, and if immunocompetent, we can use bacteriostatic, but still it is not hard and fast. Pregnancy, usually the penicillin, cephalosporins, macrolides, they are called relatively safer in pregnant women. So we can use them, and in contrast, the tetracycline, metronidazole, aminoglycoside, they are said to be harmful for either pregnant women or for the fetus. So we should avoid their use. The next factor among the host factor is prior antimicrobial therapy. It is mostly the cases in hospitalized patients. Hospitalized patients might have received prior antibiotic therapy, and there are high chances of resistance, and accordingly we have to select the antibiotics. Genetic factors like primaquine, nitrofurantoin, sulfonamides, these antimicrobials are known to cause hemolysis in glucose 6-phosphate dehydrogenase enzyme deficient patients. So in these patients, we have to be very, very cautious while selecting antimicrobials, rather we should avoid these antibiotics. Fine. Now if we talk about the drug factors, in drug factors, the important one is spectrum of antimicrobial. This is the most important, that we have to know from our textbook knowledge which antibiotics are effective against which pathogen, without which we will not be able to select an appropriate antimicrobial. And as a dictum, we should use antimicrobial that is as narrow as possible of the spectrum, rather than the extended spectrum or broad spectrum. Fine. Then type of antimicrobial activity and post-antibiotic effect. Like bactericidal, in most of the cases, bactericidal drugs have a prolonged post-antibiotic effect, and they should be used in immunocompromised patients. Whereas bacteriostatic drugs usually have, or they do not have post-antibiotic effect, prolonged post-antibiotic effect, and they are preferred in immunocompetent host. Then safety profile, obviously we should use antimicrobial agents having better safety profile. Then the next important parameter is pharmacokinetic property. One of the example I have given for fluoroquinolones and prostatitis. Like this example I have taken from The Pharmacological Basis of the Therapeutics by Goodman and Gilman. So if we talk about levofloxacin, so the failure rate for levofloxacin is almost 0% in urinary tract infection. It becomes 3% in pulmonary infections, and it reaches to 16% if we use it to treat skin and soft tissue infection. The reason is its pharmacokinetic properties. Fluoroquinolones achieves high levels in urinary tract and the least level in skin and soft tissue infection because of its kinetic properties. So this is very important consideration while selecting appropriate antibiotics. Like if we are to treat CNS infection like meningitis, so we have to use the antibiotics that have high penetrability that can easily cross the blood-brain barrier, like cefotaxime and fluoroquinolones for prostate. Next, among the drug factors is route of administration. As far as possible, we should use least invasive route. Like if we are using the antimicrobial on outpatient basis, we should use oral. I have seen many of the practitioners, even in outpatient, they prescribe ceftriaxone or amikacin just for urinary tract infection as first line. So route of administration should be least invasive route. Fine. The invasive route can be used in hospitalized patient, more sick patient as compared to the less severe patients. And if all other factors are similar, okay, all other factors are similar, we should use cheaper drugs as compared to costlier. Now, a single slide for aware classification. As in the previous session, it was told that WHO tells a aware classification. It divides the antimicrobials into 3 classes, and I have given just few examples of these groups. So access group antibiotics has least selection of antimicrobial resistance, and reserve group we should reserve for severe infection, or we should reserve them as a last resort. Fine. So this is also an important consideration while selecting antimicrobial. I have just put 2 simple cases, not for in-depth discussion, just for sensitization purpose. And the scientific content of the cases I have taken from CDC and Infectious Disease Control Society of India 2023 update. Here, a non-pregnant, non-lactating lady experiences dysuria, frequent voiding of volumes, and so this is a case of uncomplicated urinary tract infection. So, what should be the first line antimicrobial in this case? Any guesses? Ciprofloxacin, I have added this case because of this reason only, because fluoroquinolones are widely used as a first line therapy for treatment of urinary tract infection, but what the guideline says, nitrofurantoin, cotrimoxazole, and fosfomycin oral should be the first line empiric therapy for treatment of uncomplicated urinary tract infection, because fluoroquinolones are still highly effective. So we should preserve ciprofloxacin for complicated cases of UTIs. This is a case, we may not read the case, just go to the diagnosis. It is a case of pyelonephritis and complicated urinary tract infection caused by ESBL producing bacteria. So which should be the first line treatment. So again, the guideline says ciprofloxacin. Fluoroquinolones. Here nitrofurantoin we cannot use because it has very less penetrability into the renal parenchyma. Why can't we use meropenem verbactam, or even a single meropenem we should use? Because if it is a case of UTI with ESBL, we should use fluoroquinolones. If it is a case of ESBL infection other than urinary tract, in those cases we prefer carbapenems like meropenem. But it is a case of ESBL UTI, we should prefer ciprofloxacin. Fine. So lastly, I want to add here that selection of an appropriate antimicrobial based on the knowledge is not difficult for anybody. We can gain knowledge from textbooks or online literature. So selection is not difficult. What is a difficult thing that I found? The difficult thing is to sensitize ourselves regarding the use of appropriate antimicrobial. That I found the most difficult thing in society. what I found in one of my friend lives in UP, and I knew from him that in each and every case of diarrhea they are treating with IV fluids with addition of cefotaxime and multivitamin injection and Avil. Each and every sore throat case they are treating with prescribing amoxiclav with tablet dexamethasone 4 milligram. So such inappropriate use of drugs are happening in the society. So where is the lack? What is the deficiency in our teaching? Is there any deficiency in our teaching? Because if we can adequately sensitize our undergraduate student, I don't think if we can adequately change their behavior, in that case, if they become adults and they start their practice, their behavior change will be very difficult. So whatever inappropriate practice is being there in our society means we are not adequately sensitized in our undergraduate time. So that is the my point. Thank you very much.
Thank you, Dr. Maharishi. It was really very nice and informative talk. Uh, I would like to add one thing that regarding fluoroquinolones. It is a very effective antimicrobial agent against, it is a reserve drug for drug-resistant tuberculosis. So we should use minimally fluoroquinolones for at least respiratory infections. We have macrolides, we have other agents, but it should be used minimally to prevent the resistance development of fluoroquinolones. So I like to end this session, and house is open for discussion. If any question is there, Dr. Maharishi is here.
Good morning, and excellent presentation by both the speakers. I think this is definitely the topic currently discussed. As per the practical experience, because you mentioned at the end that is there any lack in our teaching?
Yes, ma'am.
I think as far as the pharmacology teachers who are all sitting here, we definitely teach them for UTI, prescribe nitrofurantoin or prescribe cotrimoxazole. There is a definitely discrepancy between what we teach and what is practiced.
Yes.
When they go to the hospital side, what they see is cotrimoxazole not prescribed, nitrofurantoin not prescribed. We conducted several prescription audits. What we observed is that for surgical chemoprophylaxis, clean-cut case, we teach them cefazolin is the drug of choice all over the world. When we talk to the clinician, because what we saw was a third generation used. So we had a structured interview with all the surgeons, the prescribers. What is wrong? The answer was, to a great surprise, cefazolin is not available. What we teach, whether these drugs are available or not. Good number of corporate hospitals, government hospitals, no, but cefazolin is not available, even if it is a clean-cut case. So that is also a very important factor we need to consider, whether these drugs are available and why doctors are prescribing. I think they are also forced, because if the patient has some infection and that drug is not available in the hospital pharmacy, at least you are doing something wrong, you are depriving the patient. So at least from their perspective, what they are prescribing is, jo bhi mil raha hai, prescribe karo at least, whatever is available. And that is why a very important thing, especially in the hospitals, we need to have the display the drugs in the OPD as well as in the ward, that these are the antimicrobials which are available. Because whatever is ideal, that may not be available. These are, our ground realities. These are the problems. Yes. So what we teach, what is practiced, there are some other factors. Everybody wants to be rational, but there are certain factors which are beyond our control. So these are second thing which I have observed is, especially the resident doctors. Our own students, eventually they become the resident, resident. One antimicrobial which is prescribed on day 1 to the patient, every day CT all, continue the treatment all. even when we know that it is only for 48 hours or maybe for 3 days post-operatively, but it will be continued for 10 days and nobody will be bothered. So there are several factors. Everybody wants to do, we want to implement it. But I think we also need to consider why this is happening. So we need to go into the root cause analysis.
Yes, ma'am.
Thank you very
Definitely, ma'am.
much.
Thank you, ma'am.
Presentation, I want your view regarding trimethoprim in prostatitis compared to fluoroquinolones.
Sir, in prostatitis cases, first line, because the penetration of fluoroquinolones is better. Trimethoprim. As per my knowledge, sir, they do not mention trimethoprim as first line.
Even MBBS textbook very clearly written, trimethoprim is a very good penetration in prostatic tissue.
Okay.
We are not using cotrimoxazole in UTI commonly due to sulfamethoxazole due to sulfa drug reaction. Trimethoprim is a very good penetration in prostatic tissue.
Okay, sir. Thank you, sir.
Antibiotic utilization policy, because I think in the top, that is the, I think the top institution, and that it has to implement all those things in the medical colleges. We don't have that much enough time, or we will take some guidance from your side there. Hmm. So what as you belong to ICMR, so please tell.
Apart from that, ICMR publishes the standard treatment guidelines (STGs) for the common infectious diseases. The last one was published a couple of years back, and the last one was published a couple of years back, and that is based on the Indian perspective and Indian data that for the treatment of the common infectious diseases. That STG I have showed in my slide. It is available in the public domain, and one of the important factors which was discussed about this implementation. These implementation related issues, because we have policies, we have guidelines, but it's not getting implemented. So for that also ICMR is taking implementation research basically to understand the fidelity, the sustainability, the scalability, and the facilitators and barriers, why a particular policy is being followed and why it is not followed. Is there any contextual equipoise or not?
The Professor Dr. Namrata Kumari ma'am to felicitate our speaker Dr. Saibil Das sir. Thank you ma'am. Now I request Professor Dr. Manish Shankar sir to felicitate our speaker Dr. Vikash Maharshi. Thank you, sir. Now it's time to felicitate our chairperson. So I request Professor Dr. Namrata Kumari ma'am to facilitate our chairperson, Professor Dr. S.K. Shahi sir. Thank you, ma'am. I request Professor Dr. S.K. Shahi sir to felicitate our chairperson, Professor Dr. Manish Shankar sir. I request Professor Dr. Manish Shankar sir to felicitate our chairperson, Professor Dr. Namrata Kumari ma'am. Thank you so much to our esteemed chairpersons and respected speakers for their presence. Our next segment of the day is Professor Dr. S.B. Pandey inaugural oration of ASPICON on the theme Nutraceuticals, Current Status and Future Perspectives in India. We are privileged to listen to a thought proverb by our distinguished orator, Dr. B. Dinesh Kumar sir. So let's put our hand together and welcome our chairpersons for this session on stage. Professor Dr. Indu Sinha ma'am, former professor and head of Department of Pharmacology, PMCH Patna, President IPS Bihar chapter. Dr. Deepak Kumar Sir, Medical Superintendent, Professor and Head, Department of Pharmacology, SKMCH Muzaffarpur. I request Dr. Asha Singh ma'am, Associate Professor and Head, Department of Pharmacology, NMCH Patna.
Thanks to the organizing committee who have given me the opportunity to chair the session of Professor S.B. Pandey Memorial Associations. You know, the Pandey is very, very close to our family, and I was very much obliged for that so many times. So I request Dr. Deepak to go further for his.
Good morning to all of you. I invite Dr. B. Dinesh Kumar, who needs no introduction. He is very much associated with me and all of the member of IPS. He was scientist G of director grade at ICMR, National Institute of Nutrition, and he also acted at Translational Science Research Services. He was consular to Uphar's PNPS and was Vice President, Nutrition Society of India. He was previously National President of Indian Pharmacological Society and National Secretary of Nutrition Society of India. So I request Dr. Dinesh Kumar to conduct this session and S.B. Pandey oration session.
Namaskar to everyone. Good morning. In fact, it's a great pleasure and honor. First of all, in the place where the Indian Pharmacological Society originated, that is from the Professor J.S. Acharya, to whom we can never forget. It is exactly 54 years back, Professor Acharya has registered Indian Pharmacological Society in Patna, and I have come to Patna 4-5 years back to get my registration certificate, and Madam Indu Sinha is present here. When the registrar came to her office to ask who is Professor Acharya, am I right, madam? So, sir, it's an honor, Dikshit ji, when you told me that you have to come. To be very honest, my mother is not well, my wife is also sick, but I have taken this opportunity so that I can also remember those people who have done extraordinary work. Now they have also given me an honor to give the Saket oration. I was very small person in Indian Pharmacological Society. At that time I was only a treasurer. And Professor Saket was General Secretary. In fact, I have ever seen a person of that leadership quality, to whom we are very much grateful to him. I have taken his young photo with a request to show you, and he died in a very young age, and it was a real shocking. We also cannot forget the Bihar on that day when December 6th, I still remember, December 5th, the conference was over, when our communal violence was there because of the demolition of the mosque like structure. They all have seen to it that we reach back to our destination. That was, I can not forget, Dr. Pandey, Saket Pandey. I don't know if he would have been surviving. he would have been the vice chancellor or a director or to a top position. That was his capacity. If his family members are there, I may like to convey wherever he is or his children, they should also grow to his level. This is with that expectation. I may like to title my topic because it is a oration. I have changed a little bit. Pharmacology, challenging and most sustaining therapeutic science. When Professor Y.K. Gupta was yesterday mentioning why pharmacology is challenging, is it just a phrase or is it a reality? Believe me, nobody might have thought COVID will come and it will open a challenge to the pharmacologist or a pharmacist or to an industry. That has really opened up the whole world that Indian pharmacologists are extraordinarily good. You might have recollected the name of Harigobind Khurana at that time. Then I still remember Dr. Colonel Ramnath Chopra, who during the British time has framed certain guidelines. So think of India, where we were and how we were actually going about it. Now, I have served in ICMR for 35 years. I retired in December 20. After the during the COVID operations, I was also in charge of one of the districts of the COVID operation. I was a task force committee member with the COVID vaccine development along with Priya Abraham under the chairmanship of Priya Abraham. Now, I am just coming to how I started my pharmacology. I am a non-clinical pharmacologist. I started my career from Aurangabad Medical College under Professor Gharpure and Professor N.L. Chadre with a small isolated equipment. Today, this isolated equipment is a gold standard. And I cannot praise, but I have to praise myself. I was one of the person who could elicit the response of histamine with 5 micrograms, 2 microgram of histamine. I could able to get the guinea pig ileum contractions. And from there I started my career, and for the first time they have given me a herbal formulation, LU52. Then Professor Sadre sir was the director, professor of this thing. He is no more. I respect him a lot. One day he brought one blood sample from the hospital and give it to me. Says that, Bharat Raj, इसको आप इलियम पे चलाइए. अब सर ये तो ब्लड सैंपल है, इसको हम इलियम पे कैसा चलाएंगे? तो आप चलाइए, कुछ करिए इसको. Then I have diluted that sample for more than 1,000 times. I have seen that ileum was contracting. Then I asked sir, आप मेरे को सैंपल दिए, इसके आगे क्या करना है? ये क्यों दिए? उन्होंने बताया कि ये this sample is a sample of a peptic ulcer patient, and where the mast cells and histamine will be high. I was just suspecting, so I have given you the sample. So imagine how the research and discovery start. That is how I have run that sample, and after that he says you take this herbal formulation, do the antihistaminic property of this LU52. Then I have started investigating on the antihistaminic property of LU52. Then I said, because you know students now also they may be anxious, what will be the research topic and how it will be turning out. I said, sir मेरा तो 2 साल बचा है, अब मैं थीसिस डिजर्टेशन का काम शुरू करा. सर ये डिजर्टेशन है. मैं बोला क्या डिजर्टेशन है सर? ब्लड सैंपल चलाया मैं डिजर्टेशन. Then he said no. First you understand. Then he put me to one professor, Dr. D.H. Nandal, who is a pharmacologist working in Pune. He says we are going to relate antihistaminic property of LU52 and a liver protection of a LU52, which can increase the appetite. When we were talking about the vigilance and all those things, at the time also the concept of vigilance there. I am talking to you 1981-82 talks. What was the vigilance talk? Periactin, one drug has come that is in the market. This is totally been abused. Periactin is given to the children for anorexia nervosa to increase the appetite stimulant. At that time, government was not having communication channels, but in Maharashtra, government wanted that periactin should be banned because it is a cyproheptidine, it is a drug addiction. So they wanted to ban, so they wanted to take a substitute. So they made me to do this Leaf 52 to be antihistaminic because it is a herbal preparation. Believe me, I did my CCL4 and antihistaminic property of. First time I have seen a probe. One magazine used to come from Leaf 52 in which I have done. And the chairman of that company, Mrs. Captain, told me that I am going to take you to Jammu for presentation of this work. I said, Madam, I don't know how to go to Jammu because I never seen out of Hyderabad and Maharashtra and other places. No, you have to come to Mumbai by train. From there we will fly you. First time I have flied. In there I was not, somebody scared me that you have to be on coat, otherwise the flight people will not allow. So I have hired a coat from a dry cleaning shop. I am sharing my experience because I belong to a very small, very poor, mediocre family. I went there. I have really seen Colonel Ramnath Chopra's lab, and still I preserve that cup. On that cup, the Jammu annual conference and Colonel Ramnath Chopra's photo was there on that. And it has really impressed me that what is Indian Pharmacological Society and what wonders they can do. From there, my career has started. Then I have been very fortunate enough that I have worked first my job in ICMR employment. Was also a little bit challenging job because I went for an interview. In the interview, Dr. Kamala Krishna Swami, because it is a oration, I should not forget to take the names. She said that we have an opportunity. We are supposed to calculate the salary structure in which on one episode of illness, how much we should spend. This is the job you have to do. And this was an ICMR work at that time. And director, she was the WHO fellow also. Okay, madam, but how to do? Then she said, our job is to monitor the prescriptions at the retail pharmacy outlets. I took the job. Then she gave me one question, and after questioning everything, there is a lacuna in this schedule. I took the paper at home, then referred my Remington and Goodman Gilman. I found 3 mistakes were there. But she was a senior assistant director. How to answer? I written, madam, very clearly. One is that there is no strength of the tablet and a capsule mentioned. Then there were no instructions before meals, after meals, these 2 things. I am telling you, sir, many of you are clinicians because you are all discussing, so I am telling you how the physician takes care of this and how it makes a change. I did that. I gave it to her. She appreciated. She gave me a job of 700 rupees per month salary. Then I said, madam, I am working with 750 rupees in private industry in biological events. 50 rupees is less. How can I join? That was the real dilemma. Then she said, you work for 3 months. I will give you a regular post. Exactly after 3 months, she gave me a regular post. So I started my survey. And this survey, I have monitored 42,000 prescriptions. This paper is in European Journal of Clinical Pharmacology. After this study, I have never seen back to my career. First time I have been interviewed by India Today Amarnath Menon, and this paper is there in India Today also, where I have monitored how the prescription percepts gaps are there existing in between these things. This was the methodology which we have followed. If you see here the drug consumption profiles, how is the self-prescription between the urban and rural area. This study we continued for 2 decades because ICMR was keen to have the patterns how the drug prescription change between the public, private, between urban and rural practices. So you can just see there is a big gap between the urban and rural area. In rural area, you can just see there is a prescription for the pharmacist is around 8%, whereas it is not there in urban areas. Now, this slide is very important, where you can come across why this rational use of drugs is there. This publication is also in the pharmacoeconomics. You can just see red line is relevant. That means the prescription is written perfectly all right. If you see the green one, it is a relevant in excess. In rural area, it is 30%. In urban area, it is 14%. Then you will ask me, sir, what is this excess? Irrelevant is irrelevant. We cannot say anything. अगर खांसी भी है तो दे दिया है इन्होंने वायरल ड्रग, ऐसा समथिंग डायरिया है एंटीबायोटिक दे दिए, तो दैट इज ऑल इररिलेवेंट. Excess in relevance is most important. What happens is, in front of the doctor, even patient is also important here. The patient also have anxiety, I should be get cured of the disease. So what they have done is that, if a doctor doesn't know whether he is suffering with a typhoid or a malaria, he has prescribed both at that time, chloramphenicol as well as chloroquine. That means एक प्रिस्क्रिप्शन में 2 दवा दे दी जो एक्सेस है. So you imagine like this, so many prescriptions were there. In some prescription, there was a B complex tablet, there was a B complex syrup, and there was a B complex injection. So this exactly the prescription profile is fact. We have to accept it. This was the work which I have taken for many years, but in the meantime, I have been asked to, this is about the antibiotic survey. In this antibiotics, you can just see one good thing what happened is, after our intervention, some antibiotic injectables have been banned. Why? Because the penicillin which was there, Procaine or whatever the penicillin, it used to be diluted and given in a 2 doses in the rural areas. They used to have that practice. And in certain places, because I was working in National Institute of Nutrition, where, how and from where the antibiotic leaching goes. So what used to happen is that these milk vendors, honey vendors, meat exporters, they take these antibiotics from primary health center and they will put into these samples. So this is how now you are coming across all the foodstuffs are with antibiotics is a practice which was going on. And this is how the whole food chain cycle get adulterated with the antibiotics, and this low antibiotic used to be a main resistant factor of the whole system. So many a times we ignore it. You can just see, can this be a good practice to be given to the injection? So my job was to prepare a film, and I have 2 films in my name. And when I saw the Professor Ranjit Rai Chaudhary sir's photo outside, I was with him in Bangkok, and I have been given an award also for the best film which I made for the public, this thing, by Ranjit Rai Chaudhary, and I was with my wife. So he asked me, who is she? I said, my wife. What she does? Sir, घर का काम देखते हैं. अरे यार, ये गलत designation है. So he changed the designation. No, she is a house manager. I mean to say, this is the way in which our professors used to be, and really thankful to you, sir. I have seen the 3 names, and all the 3 names we know very well. And that is how we have to recall this. Sir, then about antibiotic picture I have shown you, and this is the intervention which we have done in a public sector, where I made a film, brochure, and all these things in a regional language, because this was WHO given me the money for the only 1 district, 3 districts to be operations. And this is my film, and this film is available on YouTube. Whoever wants, I will send a link to you. With the English caption it comes, and all the heroes are from my institute. I am not actor, I am only a director. But three concepts at that time ICMR was keen. One is the injection needles which were used, and AIDS were getting propagated. Then vaccination should be mandatory. Then antibiotics should not be used, and all forgery doctors should be stopped. These are the three concepts. It is a 36-minute film. You can just take and have a look in that, sir. This is the funding which I have received for this film. And it is on a beta cam. At that time, beta cam is the advanced system. Now I have translated into this thing. Here, how the political leader, in spite of keeping a board outside, here antibiotics are prescribed and rational, but this political leader enters. This boy requires only oral rehydration, but he dictates the term to a doctor, and this has become a big hit there in that place. Then we came with this concept of antibiotics. Two parts of the capsule, one will be laughing, another will be crying once you stop the antibiotics. Now, my second phase of study, where I must recall that I am so fortunate to receive the Young Scientist Award of Achari Prize in Indian Pharmacological. At that time, I was neither an office bearer nor a known figure. I just went to Ahmedabad, and Dr. Dhawan sir, who is no more, he was the judge. He called me, "You have done excellent presentation." So imagine a pharmacologist working on environmental sciences. But I may like to share many of you, after doing that study of this survey of drug utilization, I was getting bored for 2 months. Then I have prepared my resignation and submitted to my Kamala Krishna Swami. She said, "No, why are you resigning?" "No, madam, ये क्या काम है? मैं ये pollution में काम नहीं करता." No, it is not correct. You do one thing. First you go, and system was there in ICMR. They have put me to a counselor. Dr. Shashikaran is the counselor. He counseled me for 2 days, 3 days. Then he said, "Don't resign. First, why anion is important." I am telling you why, because when I see Patna or any places, some 3-4 places, we have samples regularly. Diphenyl sodium drug, which we give DPH. At that time, we have to give something like a 25 milligram, and your plasma level should be maintained around 20 microgram per deciliter. Then you will not get epileptic shocks. Anything less, anything more, it leads to adverse reaction, and epilepsy used to be there. Our monitoring was only 20 microgram was the monitoring system. We found that Indian subjects receive 20 microgram per deciliter in a span of 3 to 7 weeks maximum. Whereas the people, the foreign people, that means international people, they take minimum of 3 months to reach the concentration of 30. Then why? Because they are the red meat eaters. The protein binding of the drug happens. So free drug availability will not be there. That is one of the cause why nutrition, interaction, and the drug concentrations are very, very, very important. So don't think that pharmacologist has only a limited role. Pharmacologist has a very big role in deciding the dosage calculations. Then I continued at anion. Then I started working on a pollution. This project is actually speaking, made me what is a learning of ethics, what is the learning of importance of this pollution. Some slides which I have put to you, that in your house, places, if these pollutions happen, you can easily report to the government. This is the important slide where you can just see that if you take calcium, magnesium to certain level, nothing will happen. If you cross your copper, zinc and this thing beyond limit, you are likely to happen the toxicity. And this is how the whole toxic substances were present. And in the maximum occupational group of population, we have monitored the heavy metal poisoning. Every case wherever you just put so many cases. And this study has brought me two important projects. One is Indo-US program, another is Indo-Austria program. In IAEA program, I am feel so happy that IAEA program, where they were planning to use the nuclear energy source for determining the heavy metal concentrations in the blood. I was also present, and I am so honored that 17, 18 countries were there. One of the person who was sitting to me was a Bangladeshi and another was Pakistani. When they were criticizing India at that time, this person used to tell me, where is your Buddha smiling man? That person has told the world what is nuclear bomb and how it should be utilized. Then I was shocked for some time. Then it was Atal Bihari Vajpayee who shown the world that India can do anything if they play with it. Now the current Prime Minister goes in the same direction, it looks. Now these are the petrol pump owners. Now I am just coming to you to certain facts where this department can take the work. Is that you have received the reports how the Bangalore frauding is happening. This is the Bangalore incident where we used to work. Next is Hyderabad, down is Delhi. Everywhere frauding has come. And whatever the vegetables which are grown under the frauding are palak, methi and all those things. So your drug metabolism, your drug kinetics, your poisonings are also the reason of this eco-pharmacological system. Therefore, your monitoring of the system is important. These are all in Telugu words, which I am just showing you how the industrial pollutants come and how they damage the whole crops. Then one of the task force which I have undertaken is against the social activist filed a case against India, how India can ban the Chinese dolls. Chinese toys have been banned by India after toys banned by America and Canada and UK. But India should not have done, because Indian toys are no better than the Chinese toys. And we were the members of this thing. So it was a Supreme Court case. And this study, actually speaking, has shaken even the Bureau of Indian Standard. Then we have completed this study where phthalate, heavy metal and how the leaching has happened. Then the question asked by you will be, why NIN is interested in this study? Why NIN was interested also, I also was really this thing, I have realized where the pharmacologist is coming here. What happens, it seems the anemia, the root cause is that the pregnant woman, after the 3 days of the delivery of a baby boy or whatever the girl, it leaves and they give one doll, and this doll will be leaching and this lady will be working there. And this leaching will have a lot of phthalate and heavy metals. And that's how the iron deficiency used to happen in the mother, and that we have to evaluate. That was our mandate. So I have been given this assignment, and we have completed this study. We have screened all type of dolls which released during the Jatra time. That means Shandy's time. In Shandy time, whatever the dolls come, they are with highly polluted and toxic material, because they are third, fourth time recycled plastic materials. So this was one of the great studies, which I still consider an honor for me. Then we have done so many studies, even still the question is that, can we, India, develop our own standards? I am just putting the question in front of everyone here, that India has to develop their own standards. We are still depending on Western standards. Western person says cholesterol 200 and next day 200 से निकाल के 150 लाता है, या नहीं तो 200 से निकाल के 300, yes 350. Why we should follow a WHO? Can't we develop our own standards? If we want to do, please participate in the all national ICMR programs or NHS programs give the data so that we can develop our own standard. We should not depend on a Western standard because it is very dangerous standard. This is how the pollution, nutrition will have an interactions. Now, then I have been assigned in 2000 a non-preclinical toxicology evaluation on par with the CSIR CDRI Lucknow institution. This has been given to me as a coordinator in 2000 with Professor N.K. Ganguly. He said, no, NIN has to do because first recombinant vaccine DNA been introduced in India. Can we think that can India develop a new vaccine DNA based or RNA vaccine in 2000? At that time, Jai Vigyan program was going on by Atalji. He says, no, it has to go. It has to come, that's all. Then Indians of Sciences Bangalore developed the vaccine for rabies. They came to Hyderabad to Indian Immunological Limited. Then they told that ICMR will evaluate, and we have evaluated this DNA anti-rabies vaccine. We are pharmacologists, we have studied many things, but going inside the molecule for me also was very new in 1999. Then I started learning what is this, how the incorporation will happen, how the vaccine is developed. It took 2 years for us to develop only a protocol. And that protocol led me to take this department further. Then I am fortunate to have a public-private program coordination with something like at least 40 industries. And during my lifespan, I have screened 34 new categories of drugs, which are most of the time recombinant. 5 foods, which I have screened. One of the food item is in the market, that is brassica, that is your sarso. That complete screening has been done by me. Product is developed by Paintal, doctor from Delhi. Still you can just see on the Ministry of Environment, my name will be there, the data is generated. I have faced 2 joint parliamentary committees. Once I have been also given a charge sheet and a memo which I will be showing you because I gave open statement in the newspapers. No problem. But this DNA vaccine is a highly calibered work. These are present in the vaccine journal and in IJMR, where we have done the monkey studies and this thing. Though our monkeys were taken away by the animal activist, but we have again brought the monkeys from Lucknow from a registered vendor, and we have seen what difficulties the animal experimentation take place. This is the report which has gone. The vaccine is in the market. Then I am sharing you some herbal formulations, how they are. I had a big collaboration with CCRA, that means Council for Research in Ayurveda and Siddha. WHO biennium program, they wanted 4 drugs to be gone under the clinical trial. They said complete the preclinical study. Out of this, one study which I am showing you, because of my compulsion, though I am retired, but I will not share the names of the products. You can just see there is a dose-dependent mortality in a preclinical toxicology for a herbal formulation which you think safe was not found to be safe. We have seen to it that it doesn't go under the clinical trial. This is the picture of that animal which I am putting in front of you. It suffered with a ileoparalytic syndrome. The mistake has happened because of the 3 principles. One is GMP, because in good manufacturing practices, the person who prepares the formulation, instead of adding 1:2, he added 2:1. This also has come to know after the investigations done with the Director General of CCRA. Then the study where we were monitoring that, there also what happens is boss is very busy. There will be a subordinate boss. He will be further busy than a boss in dictating the task. And वी विल नेवर टॉक टू अटेंडर. अटेंडर से हम सुबह फ़ोन करके क्या पूछते, अरे देख लिया एनिमल चल रहा, हाँ चल रहा सर, एक्टिव एक्टिव. But have you seen? We have never seen. Why? Because attender never goes there. वो 2 दिन में जाएगा, भूसा निकाल फिर रख देगा. But what is happening to the animal? He has to report. So animal activity with a filter paper technique, we have to understand whether it is passing a urine or a solid stool. If it is not passing, that means there is no proper physiology. But टॉक्सिकोलॉजी मीन्स क्या है? आ गए, अच्छा सर ठीक है, आप OECD का प्रिंसिपल पकड़ लीजिए 414, एक 25 एनिमल लो, ठोक दो, मार दो, खत्म, रिपोर्ट. इट इज़ नॉट करेक्ट. वी हैव टू गो बाय द दिस थिंग. एंड दिस टॉक्सिकोलॉजी में ये इलियोपैरालिटिक सिंड्रोम है, जिसमें एनिमल intestines, stomach has dilated when the drug was given, and this drug has been withdrawn for the clinical trial. I am giving you one more example why preclinical toxicology has a lot of vital role. You just see, this is one peptide. This peptide is supposed to go as an anti-cancer peptide, which was working very well. You can just see by the tail we are giving this peptide. VC means it is a saline. If you go to a therapeutic dose, there is a inflammation on the tail. If you come to average dose, it is a black, it has become. If you go to the high dose, 5th dose में आपका tail knockout हो गया है. That means complete apoptosis has happened. Whether it is true or not, we will see it with this specific animal. Same thing has happened in rabbit with a higher dose. When they submit this application to the drug controller, they said, please do the study in a dog. And in the dog, I was also the member of that study in IND. And in the dog study, the same data has come. Believe me, after the permission they got to do the trial, the same data has come in the human clinical trial. Drug is good. How they have calculated ED50 is also we have to think about it. That means there was one slide when I came here, they were showing you ED50 calculation. Mortality of animals is 70%. Tumor regression is 100%. But tumor regression is 30%. Mortality is the survival is 70%. That dose is important. You go with that dose. मैं 5 minutes में मैं खत्म करूँगा. No. So these are my press. This thing you can just see. BT brinjal is safe anion. I have been issued a memo, but now everybody is eating a BT brinjal. Enjoyed a lot in my institution. Enjoyed a lot working with Indian Pharmacological Society. Enjoyed with my friends, colleagues, learning the things. Though we used to sit for small this thing, and these are all my patents which are been filed with ICMR, and scientific experience journey is continued with a lot of expert committee members. I still go in a month 10 to 12 days to many expert committee meetings, and I may just like to advise you that if you are offered a seat on a rocket, don't ask which seat. मेरे को विंडो की सीट चाहिए ये मत पूछिए आप. रॉकेट में पहले बैठ जाइए. That's all I may like to advise you. This is where we have to get on and we have to work together. And these are my team members, from research scholar to my directors. Every face is there. And I am really thankful to my ICMR Nationals of Nutrition, where I worked for 34 years. I advocate that natural things cannot be substituted by a pharmaceuticals at any pharmacy counter to build your health. This is my slogan, and it is a powerful picture which everywhere I focus. Thanks a lot for this great honor given to me. Thank you very much.
Our Joint Organizing Secretary, Professor Dr. Hitesh Mishra, Additional Professor, Department of Pharmacology, IGIMS, to come over the stage and read out the scroll.
खुशबू फॉर इनवाइटिंग मी टू रीड आउट द स्क्रोल. और जैसा कि दिनेश सर ने बोला है कि रॉकेट में बैठना हो तो सीट नहीं पूछनी है, तो आई टेक दिस अपॉर्चुनिटी टू रीड आउट द स्क्रोल देयर. But before that, I would like to call upon on the dais Dr. Dikshit sir. Please sir. इसका रीज़न ये है कि साकेत बिहारी पांडे सर के दो शिष्य हैं, एक दीपक सर हैं और दूसरा दीक्षित सर हैं। तो सच्ची श्रद्धांजलि तभी होगी जब दीक्षित सर भी आ जाएं। Okay, thank you, sir. So, this is the Professor S.B. Pandey inaugural oration of ASPI, and for Dr. B. Dinesh Kumar, sir, as sir has already introduced and he had told about many things about them. I will just take you can say some short cut there. With a remarkable career spanning over 4 decades, sir, stands as a paragon of excellence in nutritional pharmacology and regulatory leadership, holding the distinguished position of Scientist G and former director of the ICMR NIN. Dr. Kumar's visionary stewardship has heralded unprecedented advancements in research and regulatory frameworks. His unparalleled contributions have been instrumental in driving pivotal changes in the landscape of PPP programs, that is public-private partnership programs, fostering the growth of the preclinical drug discovery in India and the shaping regulatory guidelines. Just in the last para is there, Dr. Bidin has authored over 80 scientific publications, including research articles, regulatory report, and the book chapters. His scholarly contributions span diverse area of the nutritional pharmacology and toxicology, enriching the scientific community understanding of nutrition, pollution, interaction, and social drug epidemiology. His written work stands as a testament to his expertise, dedication, and unwavering commitment to advancing knowledge in the field. Thank you, sir. And regarding S.B. Pandey, sir, मैं 14 में ज्वाइन किया, 14 से लेके अभी तक सर से लगभग ऐसा कोई क्षण नहीं जाता कि पांडे सर के बारे में ना सुनते हो। और रियली शायद हम लोगों का दुर्भाग्य बोले, ऐसा बोले कि साकेत बिहारी पांडे सर बहुत कम उम्र में ही हेवनली अबोर्ड हो गए, but he was really a gentleman there, as what we are hearing from Dikshit sir. So regarding S.V. Pandey sir, Professor S.V. Pandey academic voyage commenced with the completion of his MBBS 1969, MD 1974 from DMCH, that Darbhanga Medical College and Hospital, Bihar, where his scholarly pursuit first took flight. His tenure as an associate professor at the same institution witnessed his exceptional prowess and unwavering commitment to academic excellence. Transferred to the SKMCH Muzaffarpur 1981, Professor Pandey impact reverberated as he assumed vital roles, including that of a professor and head of pharmacology department and ultimately the principal. His administrative acumen, marked by an exceptional ability to elevate medical institution standards, brought forth lasting improvements. Notably, Professor Pandey played a pivotal role as a member of the project committee for the establishment of prestigious Indira Gandhi Institute of Medical Sciences, Patna, a monumental achievement that laid the foundation of superlative healthcare advancement in Bihar. Elected as the General Secretary of IPS in 1991, Professor Pandey contributed significantly to its growth. Professor Pandey's departure in 1997, that is very early age, left an irreplaceable void in the medical fraternity. But his enduring legacy lives on, a testament to his visionary leadership, administrative finance, and unyielding dedication to medical education governance. His life work continues to serve as an inspiration, guiding future generations towards a path of brilliance and transformative impact.
Kindly felicitate our esteemed orator, a pillar of scientific excellence and regulatory leader, Dr. B. Dinesh Kumar, sir. Now it's time to felicitate our chairpersons. I request Professor Dr. Deepak Kumar sir to kindly felicitate Professor Dr. Indu Sinha ma'am. I request Professor Dr. Indu Sinha ma'am to kindly felicitate Professor Dr. Deepak Kumar sir. I request Professor Dr. Deepak Kumar sir to kindly felicitate our Dr. Asha Singh ma'am. Thank you so much to our esteemed chairpersons and speaker. Start our next symposium on immunotherapeutic in cancer. So let's put your hands together and welcome our chairperson on stage. Professor Dr. Rajesh Kumar Singh, Professor and Chief, State Cancer Institute, IGIMS Patna. I welcome you, sir, to please come on the stage. Then Dr. Ridu Kumar, sir, who will guide us through the proceeding, and I'll request you, sir, to take the floor and commence the session.
Me as the chairperson, this is really relevant to my topic as I'm a radiation oncologist at here. So just I may like to invite my very best friend in clinical hematology, Dr. Avinash Kumar Singh, to present his topic on small molecule inhibitors in hemato-oncology. And this is very important topic, and he'll enlighten us with this topic. Thank you.
Thank you. And good morning, everyone. I would like to first thank organizers, especially Dr. Harihar Dikshit sir, for giving me opportunity to speak today. And my topic is small molecule inhibitors in hemato-oncology. And while preparing this presentation, I came to know that how less will we know about drugs that we use in our day-to-day practice. So we need to learn more about pharmacology, and I wish I could attend more such conferences. And the two talks that I attended just now, especially by Dinesh sir, was really enlightening. Description of leukemia, it started from around 1847 when term leukemia was introduced by Rudolf Virchow, and first time the cause of death as leukemia was reported in 1970. So these are first initial descriptions of cases who were reported as leukemia. So initially we were not knowing what is hematological malignancy. Then gradually we came to know about hematological malignancy, especially leukemia. Then the pathogenesis and different classification system by WHO pathogenesis study, it has enlightened us about disease and what is the problem in a particular disease, what different types of hematological malignancies are there, and gradually therapeutics also has developed. So initially when we had, if you see the history, so we had only palliation as the treatment, where we used to give painkillers and whole blood transfusion to just palliate the symptoms of anemia or thrombocytopenia. But with the introduction of more chemotherapy, we started having patients who used to survive for weeks or months, and then the combination of chemotherapy has led to cure in certain number of patients. And but chemotherapy use is just like bombarding a place where you have to target one building, but you affects other parts of normal area too. So chemotherapy has lots of side effects, and you all know, and our patients and society, they are scared of chemotherapy, their side effects, toxicity. So from chemotherapy, we have moved to more specific area like targeted therapy, where we use more efficacious drug with less side effects. And also, the other parts of hemato-oncology treatment in recent days is cellular therapy like hematopoietic cell transplant and CAR T cell therapy, immunotherapy. They are the backbone of current hemato-oncology management. So these are some definitions which are important, like what is chemotherapy. So they are drugs to kill fast growing cells. Immunotherapy or biological therapy, they uh, deal with immune system. They either activate or suppress it. Cellular therapy is transplant, like a stem cell transplant. Targeted therapy, I'm going to discuss in brief detail, where there is a specific targets, mutation or gene that you target, and it has got less side effects and better efficacy. And a small molecule inhibitor is one type of targeted therapy where the size is very small, like 1 nanomole. So targeted therapy can be divided into two: micromolecule or a small molecule inhibitors, where size of drug is less than 1000 Dalton, and macromolecules, where size is more. That is, they are monoclonal antibodies. We use rituximab very often, polypeptides, antibody drug conjugates like brentuximab, verotin, or inotuzumab ozogamycin we use for ALL, and nucleic acids. So these all I have described. So small molecule inhibitors, they have difference from macromolecules in their pharmacokinetic, cost, patient compliance, drug storage and transportation. And it has changed the management of medical oncology and hemato-oncology for sure. So first time the small molecule inhibitor which came into use was Gleevec, imatinib, which was introduced in 2001, and it was so breakthrough in the field of hemato-oncology that this was described in Times magazine. So you can see we first had imatinib in 2001, and after that around 89 molecules has been approved both in solid and liquid oncology. And the beauty about imatinib is that this is the only drug which was introduced in 2001, and it is still has stood test of time for last 22 years. So whenever a new drug comes, we have hope that it will sustain for 6 months, 1 year, 2 years. Whenever second generation drug will come, it will be replaced. But this is not true about imatinib. Even in 2023, this is the best drug for chronic myeloid leukemia. So these are many types of small molecule inhibitors that we use, like kinase inhibitors, receptor TKI, non-receptor TKI, serine, threonine kinase inhibitors, epigenetic inhibitors, hedgehog pathway inhibitors, proteasome inhibitors, and PARP inhibitors. So we, as a hemato-oncologist, we don't use all of them, but there are around 15-20 small molecule inhibitors are there that we use. So I will just briefly touch upon 3 to 4 molecules which are important for us. So this is just about how receptor protein kinase dependent pathway they act. So these are all molecules, intracellular pathway, they lead to cell proliferation and apoptosis. So coming to first the tyrosine kinase inhibitors. So this is the receptor tyrosine kinase activation. So two receptors are there. When ligand binds, they become dimers, and there is on effect. So cellular proliferation takes place, and this happens in malignancies too. So this is the landmark study which has approved imatinib as first-line treatment for chronic myeloid leukemia. And before 2001, we used to use interferon and cytarabine combination, but this imatinib has changed the life of CML patients, or we have to do hematopoietic stem cell transplant for CML patients. So this was a phase 3 randomized controlled trial. It was published in NEJM, where imatinib was compared with interferon and low-dose cytarabine. And this is how imatinib acts. So there is ATP binding site at BCR-ABL which is occupied by imatinib. So there is dissociation of substrate and effector, and the chronic myeloid leukemia stem cells, they don't get stimulus, they don't proliferate. So this is a study. Around 500 patients were there in both the group, and the baseline characteristics were matched, and you see the results. So the complete hematological response as well as cytogenetic response were far better in imatinib group compared with the combination arm. So all these survival curves were better in imatinib compared with interferon and cytarabine arm, and this IRIS study had concluded that imatinib is significantly superior to the combination of interferon and low-dose cytarabine. And after imatinib, many second generation and third generation TKI also has come into use, but they have not replaced imatinib as first-line treatment. They are beneficial for patients who have failed imatinib. Around 15 to 20% of patients, they have failed imatinib. So for that, second generation TKI are there, like nilotinib, dasatinib, bosutinib, ponatinib. Their side effects are there, and they are also costly, but many generics have come where the cost is less. And these are all about mutations, why patient develops imatinib failure, and depending upon mutation, and we choose the second or third generation TKI in our patients. Now coming to BCL2, this is BCL2 inhibitor is also a small molecule inhibitor, and in hemato-oncology it has become very frequently used in different types of hematological malignancy like acute myeloid leukemia, multiple myeloma, CLL. So briefly we will touch upon. So apoptosis in cancer, they have intrinsic pathway and extrinsic pathway, and we have found that there are many malignancy where BCL2 is overexpressed, like AML, multiple myeloma, CLL, mantle cell lymphoma, and many other malignancy where the work is going on. So this is just to show that BCL2 is an anti-apoptotic gene. So what happens if BCL2 is blocked by BH3? BH3 is a pro-apoptotic, so there will be cell death. But in malignancy like malignant lymphoid cell or acute myeloid leukemia, what happens? BCL2 is overexpressed. So there is so much BCL2 that will not be blocked by BH3, and so that leads to cell survival in malignancies. So if we have BCL2 inhibitors which can block all BCL2, we can lead to apoptosis and cell death, and we can have better response. So this is the way it was introduced. This is just I have said. So the BCL2 inhibitor that we use in our clinical purpose is venetoclax. Unfortunately, it is not available in India, so we have to procure it from outside. And almost all hemato-oncology who treat AML, multiple myeloma, and CLL, they use venetoclax from outside. So this is all about venetoclax. It's a BCL2 inhibitor, BH3 mimetic. And in different malignancy, different doses are there. Like for CLL, we use 400 milligram. For AML, 400 milligram. It's orally administered. 99.9% excreted in feces, and these are the most common side effects, like as expected, hematological myelosuppression is the side effects. And this is all about predictors of response to common disease where we use venetoclax is CLL and AML, and many studies have come where we have started using venetoclax in frontline settings. So whenever we use this type of venetoclax in malignancy, there is risk of tumor lysis syndrome. So this diagram just say that how to risk stratify and use hydration and other drug to control tumor lysis syndrome. And these are all about safety profiles. So almost all combination of venetoclax has myelosuppression as side effects, the thrombocytopenia, leukopenia, neutropenia, anemia, other than GI side effects like diarrhea, nausea, vomiting are the common one. And this is how we use in CLL. So we have to start with lower doses, 20 milligram in first week, then 40, 50, and we go to 400 milligram. In acute myeloid leukemia, there is fast ramp up where we use day 100 milligram, then 200 and 400 milligram is the maximum dose we use with azacitidine. This is all about how to ramp up the dose and use tumor lysis syndrome prophylaxis. And these all drug has interaction with different drugs, so that is also beneficial for our patients who are having financial problem. So if we use 400 milligram dose, they will have to have 40-50,000 rupees per month. But what we use antifungals in acute myeloid leukemia, which increases the concentration of venetoclax. So with voriconazole or posaconazole, we can reduce the dose of venetoclax with similar efficacy. And these are all about approved indications of venetoclax like CLL, AML, mantle cell lymphoma, and also in multiple myeloma who are having translocation 11-14. So these are all how to dose modify in in CLL. Suppose if there is side effects grade 3 or 4, then we have to stop it, or we have to restart when there is grade 1 side effect is there. So this is all about how to reduce the dose of venetoclax in CLL. And this is regarding dose modification in acute myeloid leukemia. So if there is severe myelosuppression and disease is under remission, then we may have to stop it. We have to see the bone marrow, whether patient is in remission or not. Then we have to restart once there is count recovery. And this is not that venetoclax is the last word in acute myeloid leukemia. Even when you use venetoclax, they can develop resistance, and these are the mechanisms why they develop resistance, like BCL2 associated mutations. There are many BCL2 family protein alterations, genomic instability, they lead to even resistance to venetoclax. So when you use venetoclax in acute myeloid leukemia, they even can progress or relapse over venetoclax. This is the use of azacitidine and venetoclax combination in previously untreated acute myeloid leukemia. So for acute myeloid leukemia, 3+7 induction chemotherapy is the standard, but it is very toxic. So many MDR infections are there that we are used to lose around 20-30% of cases because of infection. So this is the azacitidine and venetoclax combination has come where some unfit or elderly patients can have better survival in combination, where we can't use the intensive chemotherapy protocol like 3+7. So this is the around 200 patients where they are in both group, and they have shown that azacitidine plus venetoclax has better overall survival compared with azacitidine alone. And this is the subgroup analysis which has shown that azacitidine venetoclax is better compared with the azacitidine alone. And these are the side effects. The combination has mainly hematological side effects as well as GI side effects. And this is regarding venetoclax in chronic lymphocytic leukemia. So this was published in NEJM in 2023. Again, different combinations of CLL acting drug were combined with venetoclax, and they have shown that the combination, the addition of venetoclax has benefit. That leads to better progression-free survival as well as overall survival. So these are all about side effects. So obviously the hematological side effects are more common, and as well as GI side effects. So this is about venetoclax for the treatment of multiple myeloma. So for multiple myeloma, we usually use triplet like dexamethasone, bortezomib, and lenalidomide, or any other third drug. But there are some subset of multiple myeloma who are having translocation 11-14, where BCL2 is overexpressed. There the combination of venetoclax in mainly in relapsed refractory myeloma has benefit. So this is the same study where when we used in patients with 11-14 translocation, there was benefit with addition of venetoclax. These are all ongoing trials of venetoclax in different indications like acute myeloid leukemia, MDS, and other hematological malignancy. Now coming to FLT3 inhibitors. So acute myeloid leukemia is a difficult disease to treat. Has a very severe myelosuppression with intensive chemotherapy, and the cytogenetics and molecules are very important to risk stratify AML. And these are all mutations which are there in AML to risk stratify, which are some are good mutations, some are bad mutations. So we have to risk stratify, and to consolidation we may have to use hematopoietic cell transplant as consolidation in acute myeloid leukemia. So these are how to risk stratify depending upon cytogenetics and molecular. And this is the FLT3 inhibitor. So the first FLT3 inhibitor that we are using in AML has come from this study ratified trial where midostaurin were combined with 3+7 induction chemotherapy in FLT3 positive acute myeloid leukemia. And this particular study where two groups were matched, around 700 patients in one, around 350 patients were there in both groups. And they have shown that the addition of midostaurin, that is the FLT3 inhibitor, in addition to 3+7 has led to better progression-free survival in AML patients. And these are all other generation FLT3 inhibitors like sorafenib and giltertinib is there, which has been approved in AML who are relapse refractory cases. BTK inhibitor, this is the last one, BTK inhibitor in the treatment of CLL mainly. So this is the BTK inhibitor structure, and these are the BTK inhibitor we use for hematological malignancy. The first approved was ibrutinib, then second generation came as acalabrutinib, which has less side effects. It is more beneficial, though it's costly, but many genetic drugs has come which has less cost, and others are still in trial. Zanubrutinib also has been approved in CLL, relapse refractory mantle cell lymphoma. So to conclude, field of hemato-oncology is rapidly expanding and new therapeutic armamentarium is added at a fast rate. Small molecule inhibitors have an important role in improving survival of patients. They are used singly as well as in combination with success, and we are gradually shifting from toxic and frustrating chemotherapy regimen to more specific targeted molecular immunotherapy and cellular therapy regimen for our patients. And though we have better drugs, we have small molecule inhibitors, we have better stem cell transplant strategies, immunotherapies, they are effective, but as well as they are costly. But as Dr. Dinesh sir has said, that we should not blindly just follow what is there in the West. We should see the hemato-oncology of Bihar is different from hemato-oncology of Delhi, Mumbai, and Vellore, and from US and UK. So we have to see our patient profile, how they accept their psychology. It's very important to fit a new drug in a particular patient. This is very important. That is, thank you all. Thank you.
The benefit of imatinib is such in chronic myeloid leukemia we call as a magic bullet. So it was just came in 2001. So it's very nice presentation, Dr. Avinash, and thank you for that. And any question regarding this presentation? one or two questions.
Thank you, sir. Thank you.
So now, thank you very much, Dr. Avinash, and now hand over to the co-chairperson
Wants
for
to ask
the
question.
next.
The BCR-ABL translocation, other test.
Yes, thank you. Nice
And
question.
other
So,
question is,
yes.
what about the HLA gene?
Yes, thank you, sir. Thank you. Oncologist, our or my, the challenging job is to diagnose. That is very important. Huh? So there are lots of limitations. You have to say that patient is having cancer or not. So there are so many things: normal variation, physiological, benign disease, malignant disease. So diagnosis should be certain, and as per WHO classification, you should not label one patient as CML unless you demonstrate the BCR-ABL translocation either by RT-PCR, FISH or cytogenetics. That is the most. It's not that you see CBC, peripheral smear, some pathologist write that this is CML chronic phase and you will start imatinib. 99% cases you can be true, but 1% can be BCR-ABL negative CMPN. They have different management, different prognosis, different. You have to counsel the patient and attendance is very important. CML is a beautiful disease where in 90% of cases you can have normal life with imatinib. So if you hit bad target like BCR-ABL negative CMPN, you start immediately. It is ineffective. It will not just waste of money. Even if 1,000 rupees per month, it is waste. So you have to demonstrate the mutation particular. Only then you should start. And second question is. Second question was HLA gene. Yes, transplant. So transplant is, there are many hematological malignancy where hematopoietic transplant is well defined. That it's suppose CML-CP who has progressed on imatinib, and it is not responding to second line agents, then you should consider a stem cell transplant. And there are some disease like acute myeloid leukemia who are having intermediate risk or high risk. There you have to do a stem cell transplant. And stem cell transplant is not a wonder therapy, it's very toxic. You do transplant, disease is cured, patient has been GVHD, another disease. He will have diarrhea, he will have liver dysfunction, he will have autoimmune disease. So you get rid of one cancer and patients are having now a second disease. So you have to have a very good balance. And in India where cost is a problem, hardly 5 out of 100 patients who needs transplant, they will go for transplant. So it's very important. Yes.
When you are going for a ML, so is there
Point inhibitors, challenge and cautions. Dr. Alok Ranjan is MD DM Medical Oncology. Ex-consultant Mahavir Cancer Sansthan, ex-assistant professor RIMS Ranchi, and
Kumar sir, radiation oncologist, to kindly felicitate our speaker, Dr. Avinash Kumar sir.
All the chairpersons. Please.
Thank you, sir.
Good morning, and thank you to chairperson and organizing committee, especially to the Dikshit sir and audience. My topic is immune checkpoint inhibitors, challenges and cautions. And immunotherapy started in 2011 in melanoma. It is a journey of immunotherapy. It started in melanoma cases, and first was ipilimumab in 2011. Now many immunotherapy are added in up to 2022, and many indications are added. Initially, in melanoma, ipilimumab is used as metastatic disease. Immunotherapy used in metastatic disease as a first line, second line, or as a neoadjuvant or adjuvant therapy. It may as a single agent or combination, or as a, with chemo or with targeted agent. Now that come into topic, that is challenges during the administration of immunotherapy. First, before administration of immunotherapy, proper biomarker or identification or diagnosis is needed. And then PD-L1 status and cost. Cost is very important, and as immunotherapy cost is about per month 2 to 3 lakh. And PD-L1 status is of cancer is much needed, as many cancer PD-L1 status if greater than in first line, in just such as in lung cancer, if greater than 10%, then use immunotherapy. Proper biomarker identification is also needed. And then during administration, anaphylaxis and cutaneous reaction can occur. And after administration, drug monitoring or adverse effects difficult to manage. Then come to immune-related adverse events. all are immune related adverse event, all are itis, that is the in brain encephalitis, aseptic meningitis, or in lung pneumonitis, in cardiotoxicity, that is myocarditis, and renal inefficiency, enterocolitis. It is all are side effect during the administration of the immunotherapy. Timing of adverse events are more important. All are developed about after the administration, after 1 month after administration of the immunotherapy. Some are long lasting, that is the nephritis. Dermatitis is the most common adverse event, occurs in greater than 50% of patients. Median onset is 3 to 4%, and management include emollients and topical corticosteroid antihistaminic. If it involves greater than 30% of body surface area, systematic corticosteroid is needed. Then come to enterocolitis. Incidence is 20 to 45%, and onsets occurs generally 6 weeks. Management, general management include electrolyte replacement and loperamide, and withhold if greater than 3 bowel activity occurs or systematic colitis develop. Then start the systematic corticosteroid and other TNF inhibitors. Then come to endocrinopathy. Endocrinopathy generally occurs in 6 weeks, and management include if asymptomatic, a TSS greater than 0.5 up lower limit of normal, withhold if high dose corticosteroid. If adrenal insufficiency occurs with immunotherapy, start with IVH, adequate glucocorticoid replacement. Then come to pneumonitis. Incidence is less than 5%, and management includes repeated imaging and clinical monitoring of the patient. Withhold if patient symptomatic, and give high dose steroid and methylprednisolone 2 to 4 milligram per kg per day. Prophylactic antibiotic may needed. Consider cyclophosphamide, mycophenolate, or infliximab if not improving. Then come to nephritis. It is rare or occurs in 9 weeks, and management include monitoring and corticosteroid treatment. Renal biopsy may needed. Then come to hepatitis. Hepatitis may incidence less than 9%, or onset is at 6 weeks. It is grade 1, grade 2, and grade 3. Grade 1 just monitor, grade 2 withhold the treatment and give prednisolone. Grade 3 to 4 discontinue the immunotherapy and start methylprednisolone. This is the case and fatality rate of different type of immunotherapies. If we come to nephritis, case rate is very less, mortality is very high. And if colitis is the case rate is very high, mortality is very low. Must watch. Diarrhea and colitis from immunotherapy predict for longer survival. This is the patient with diarrhea, and this is the patient without diarrhea. Here it is the overall survival rate. Patient with diarrhea have longer overall survival rate, and patient without diarrhea have less overall survival rate. Then come to hyperprogression and pseudoprogression. Hyperprogression is a rapid increase in tumor growth rate after starting a new treatment, and pseudoprogression is an initial flare-up, followed by tumor shrinkage after starting a new treatment. There is no consensus guideline for definition of hyperprogression or pseudoprogression with immunotherapy. Implication of clinical practice and research. Some patients worsen dramatically with immunotherapy. Hyperprogression is more frequent than pseudoprogression. Under rapid deterioration, consider to stop immunotherapy. If hyperprogression confirmed due to immunotherapy, it should be managed as immunotherapy severe toxicity. More studies needed to assess hyperprogression and pseudoprogression with immunotherapy. Then come to autoimmune disease and checkpoint inhibitors. Autoimmune disease patients frequently exclude from immunotherapy clinical trials due to the possible higher toxicity rates. High frequency of cancer or concomitant autoimmune disease occurs. In lung cancer, it is 24%. In renal cancer, it is 30%. Few data assess effectiveness and safety of immunotherapy in patients with cancer and autoimmune disease. Patients with autoimmune disease at higher risk of immune-related adverse event, but frequently manageable. Autoimmune disease should not be a formal contraindication of immunotherapy. Steroid and checkpoint inhibitors. Immunotherapy trial exclude patients with steroid treatment due to the risk of less efficacy or higher toxicity. Dexamethasone suppress the function of activated T lymphocytes by enhancing the expression of PD-1 and inhibition of IL-2 and TNF-alpha and induction T cell apoptosis. Many patients need steroid before at treatment, at starting, during, or even after immunotherapy treatment due to the comorbidity for treatment and toxicity management. Controversial evidence of less benefit of immunotherapy with steroid. Follow the guideline of ESMO or NCCN. Other clinical use of steroid with immunotherapy should be considered under careful vigilance. Now come to immunotherapy resistance. It may be primary resistance or acquired resistance. There is a multiple factor of immunotherapy resistance such as genomic factor, tumor heterogeneity, cancer microenvironment, and some drug and cancer cell interaction. This is the definition. Primary resistance. Resistance occurs when cancer does not respond to the treatment which have never been used in this patient before, and acquired resistance already used. How to overcome the resistance to immunotherapy? By use the dual therapy, by use the other metabolic inhibitors with immunotherapy, or use immunotherapy with targeted therapy such as BRAF inhibitor, MAC inhibitor, VEGF therapy, or use the epigenetic modifier, or use with immunotherapy or radiations. Then come to immunotherapy with VEGF therapy. Indication are hepatocellular carcinoma, RCC, and endometrial carcinoma. But when you use immunotherapy with anti-VEGF combination therapy, side effect of both, that is immunotherapy all itis, and in VEGF therapy such as other side effect of VEGF therapy added. Thus, to conclude my message, immune checkpoint inhibitors have revolutionized the field of oncology, offering new hope to patients with various types of cancers. These drugs, which unleash the power of immune system to fight cancer, have been extraordinary success in some cases. Their potential to invoke long-lasting response amplificity of wide range of cancer make them a crucial tool in our fight against cancer. However, issue of limited response in some patients, immune-related adverse event, and higher cost is a significant challenge. As we look to the future, it's essential to focus on addressing these hurdles, discovering new target, overcoming resistance, and developing effective combination therapy. Thank you.
Thank you, Dr. Alok, for excellent presentation. Actually, immunotherapy is nowadays very useful for a particular subset of cancer patient, particularly head and neck cancer, lung cancer, and melanoma. And at present, if you ask me one question, what is the treatment modality with which we can expect longer progression-free survival or longer survival, even the complete response in advanced stage patient, then the answer is immunotherapy. I have few patients with the lung cancer, stage 4, and all the receptors negative, and now they are surviving even after the 5 years. So immunotherapy works wonder in few patients. Thank
you. Thank you very much, Dr. Alok. If in any question, we can invite the next speaker. So I just request our co-chairperson, Dr. Sanjay, to invite them. Dr. Alok, please.
I invite Dr. Sanjeev. He is an additional professor in the Department of Community and Family Medicine at AIIMS Bhopal. He has a very good career throughout, very academic, comfortable in academics, and last recently actually we met in MD exam. Fortunately, we were at a place where the MD exam are going on. So I was actually knowing personally him, not by face, but I was knowing on WhatsApp and other group that he is actually basically from Bihar, and he's very nice, cool. We will get a lot of information from his talk on vaccines. So just start. Thank you for being here and giving time us for our audiences.
Thank you so much, sir. The privilege is all mine. At the outset, I will specially thank Dr. Dikshit, sir, because he is also my guru. I graduated from Sri Krishna Medical College, Muzaffarpur, where he was a teacher there. Then Dr. Sanjay, sir, happens to be one of my seniors from a postgraduate institute, AIMS Delhi. And then I had had some instinct with many of the colleagues. I have some colleagues who are working at IJMS and at PMCH and at AIMS Patna also. I have been given a topic which is quite new and not much is known, not much is being practiced about this topic. So I will take this as a challenge as well as I will take this as an opportunity for all of us to maybe think about it. And I will also like to add here that maybe I belonging from the domain of community medicine, I am one of the voices which is putting the agenda of the people, the community. So the vaccinations is mostly from the patient reported outcome perspective. We are often talking about the clinical perspective. This is something which is related to patient perspective. So this will be the outline. I have a habit of putting forth the resources first, then we'll go to the context. As you can see in the resources, we don't have much to offer from our own country. We don't have much research going on, much information in the usual textbooks which we use. So the context can start from this famous movie line, "Saathi haath badhana, ek akela thak jayega, milkar boj uthana." The entire session is on that. We are talking about immunity, and when the immunity fails, maybe it needs an aid, some kind of support. So the support is needed because the patients, we all know that they are at higher risk of developing infections, and that is the perspective the patient has. The patient doesn't understand usually that he or she has stage 3, stage 4, stage 2 cancer. He is sick. He may become sick because of fever. He doesn't understand or she doesn't understand this fever is because of the cancer or is it because of some infection. And when we are talking of vaccines, we are essentially talking of infections. So let's go into it. We know the risk of this higher infection is because either of the underlying malignancy or because of the agents which are being used, which reduces the immunity of the patient, which is supposed to reduce the immunity of the patient to kill the cancer cells. We all agree that out of the few miracles of medical science, vaccine is one of them. So there has been reports which has underlined vaccination as the best miracle from the medical science which has offered in the last 100 years. So we may agree to it completely, we may not agree to it completely, but they are really useful. And the evidence based for use of vaccines in cancer patients are slowly growing up. So we have some information, we have some evidence what is available, what is offered. I happened to, before when this topic was given to me, so I talked to the oncologist at my institute, and to my surprise, I didn't find it to be a norm that vaccines are even considered to be as an advice when cancer patients are coming to the OPD or coming to the IPDs. So we have something to add. And if we are interested in research, especially for the students, graduates, postgraduates, it might be a good idea to do something in this direction. So what are the challenges when we are talking of vaccine or vaccinations for cancer patients? We all know that there is altered immunocompetence. So this altered immunocompetence will manifest in two ways. So it will manifest either because of safety consideration by in using live vaccines. So since the patient is having low immunity, these live vaccines, the vaccine organism can have an uninhibited growth. Or we can have effectiveness concern. We have non-live vaccines which need the immune cells or immunity to actually work. So if the immunity is either low or not working, those vaccines are not supposed to work, will not work probably. Then as a clinician as well as a public health professional, we need to also explore the area of risk of exposure to infections to the cancer patients. What is the local epidemiology? Do we have information on the burden? Do we know what is the clinical prediction or what is the pre-test probability of the next person walking in the OPD to be suffering from a serious or a usual infection? And especially we had a good talks on antibiogram. So what is the local antibiogram and whether we have antibiotics available to treat those infections. And being from the preventive medicine background, and I hope all of us are from that understanding that we also need to add something in the armamentarium, so apart from antibiogram. So we have the challenge of whether we have this information or not, and a very untouched topic, the contacts. So we have even not, when I was talking to my colleague, they didn't even consider healthcare professionals to be as a contact. So healthcare professionals who are treating the cancer patient, they themselves are contacts. They are going to hand, although we have universal precaution, but they are going to probably either get infected or give the infection to the cancer patients. So we need to know what is the current practices in occupational health. By occupational health, I am trying to say that whether the doctors, the nurses, the other healthcare staff, are they immunized? Are they going to be risk to the patient? We don't know much on that. And the prescription inclusivity for the contact. Contact here, I mean the household contact or the caregivers of the patients. And another key challenge would be testing of immune status. So we know how immune status can be tested. It can be based on usual tests like CBC, or it can be something advanced like leukocyte proliferation assay, which I came to know, and I talked to our colleagues at AIIMS Bhopal, and it was not being practiced. I asked him whether it's available in the city. He said he doesn't know. I talked to the people in private in that city. It was not available. So are we able to actually assess for this or not? We don't know that. So that may delay the decision making. How is it relevant when we are talking of evidence-based healthcare? So when we are talking of evidence-based healthcare, we should think of some questions like which cancer patients will need vaccination? How many of those cancer patients are there? If I have 40 patients every day or 30 patients every day, how many of them really require those vaccines? How effective are these vaccines? Their effectiveness may have been tested in usual people. Have they been tested among cancer patients? That kind of information is required. What will be the additional cost? Some vaccines are really cheap. Some vaccines are considered to be cheap because they are available free because of the government program. If we try and buy them in market, it might be really costly. And really important, what is the opinion of the doctors as well as the patients? Do the doctor really consider them to be important? Are the patients even given the option of shared decision making? A very important concept in family medicine. So when we are talking of these, let's have a glimpse of what has really been happening in our country. For elderly, the uptake of influenza or say, for example, pneumococcal vaccines, which are really very important causes for severe infections, are quite low, very low, less than 1%. A good thing was that among cancer patients, a study reported that it was higher. So you can say between 2 to 7%, there was a coverage of different vaccines against some of these important diseases. We found in one of our study in Bhopal recently, very recently, this year only, that among adolescent school children, this is especially important because I'm trying to prove a point here, that the coverage of TT vaccine for school girls or school boys in adolescent age group, it was quite low as compared to the coverage in COVID-19 vaccination. So motivation beyond mandate, there is an issue. So the mandate is there that a particular age group of people should be vaccinated, but there is a problem with motivation. We need to explore that motivation. We had talk about behavior change in the morning. Many esteemed speakers were talking about that. So what is the mandate? In India, we have an agency of Government of India, Ministry of Health and Family Welfare, called as National Technical Advisory on Guidelines for Immunization, NATAGI, which was made online of something called a ACIP of CDC, which gives the vaccine guidelines for on behalf of CDC to Government of USA. So this very esteemed body has had 17 meetings in the last nearly 16, 17 years. Surprisingly, they don't have the mandate to give guidelines on adult immunization. Forget about cancer immunization for cancer patients. So we are still there. We are moving forward, but we have miles to go. So this NATAGI or Ministry of Family Welfare, they gives guideline on National Immunization Schedule and other schedules. WHO has SAGE, which uses systematic reviews of published literature and provides position papers, which is published in weekly epidemiological records. So we can, whenever we have to know the real science of vaccines, we can check the relevant weekly epidemiology records. The link is here. We can check it from there. For cancer patient, I could find two bodies who provide guidelines. So one of them was the Infectious Disease Society of America, which is an association of infection or maybe immunologist, and one regulatory body, which is the ACIP. I could not find anything from Ministry of Health or Family Welfare or API or IAP or other bodies. So what are the types of vaccines which are available, which are there for the cancer patients? So they can be preventive. As we all know, vaccines are usually preventive. They can also be therapeutic, which was a new learning for me also. Then there are certain therapeutic vaccines also. And when we talk of vaccine, then we should also consider these vaccines for contacts. So what are the key guidelines? So some of the key guidelines are, if the patient is going to be given chemotherapy or radiation and wants to get or should be get vaccinated, and if the vaccine is for inactivated, 2 weeks before, for live vaccines 4 weeks before. And if the patient has already been given chemotherapy or radiation, we need to wait for 3 months till we can give this inactive or live vaccine. There are some special categories. Say, for example, if the patient has received hematopoietic cell transplant, then the person needs to be vaccinated as if the patient has never been vaccinated, because the entire memory cell armamentarium is gone. So the patient, we all know that cancer patients can be small kids to an elderly person. So even for an elderly person or even a middle-aged person or a young person, they need to be revaccinated as for the data. And there are guidelines for that. Since we don't have guidelines for India, right now we need to follow whatever is available globally. If the patient has been given corticosteroids, we saw in many sessions that corticosteroids are often given for taking care of side effects, then we need to wait for a month. If the patient has received anti-B cell antibodies as a therapeutic regimen, then we need to wait as long as 6 months. And good thing was that for patients who require COVID or influenza, because we know that one of the commonest infections would be ARIs, and they would be caused by these and their related organisms. Vaccines are available, effective vaccines available for these. So these can be given during chemotherapy also, but we can wait for maybe 15 days till the immune system recovers. These are some of the famous examples. We all know these are examples are there in the National Immunization Schedule also. So live vaccines are MMR and varicella vaccines. The inactivated vaccines work against diseases like influenza, pneumococcal, hepatitis A. Influenza has also recombinant vaccine like vaccine for zoster or hepatitis B. Hepatitis B is nearly recombinant vaccine now because of concerns that the process may lead to HIV infection. So now we have mostly recombinant vaccine for hepatitis B. Some interesting examples like Sipuleucel T. This is a therapeutic vaccine made of dendritic cell, and they are used for advanced prostate cancer. There is another vaccine or immunotherapy you can call, which is TVEC, which is works on the principle of oncolytic virus, and they are used for melanoma. They are injected inside the melanoma tumors, and we all have been reading about BCG and its role in bladder cancer. So the recommendation by ACIP, this is what it says, that for people who are immunocompromised, some vaccines are contraindicated. This is for USA. So vaccines which are live influenza or live measles, MMR or varicella, they are contraindicated. But vaccines which are given against hepatitis A or meningococcal, either of the antigens, they can be given if the patient also has any additional risk factor. Say, for example, the additional risk factor can be age, it can be some other factor. So they can be given. And then there is a list of these green vaccines which should be given, offered to all the patients who are reporting with cancer. So vaccines like vaccine for COVID, vaccine for influenza, which is inactivated one, for zoster, recombinant one, or for pneumococcal, especially pneumococcal. So patients who are expectomatized or doesn't have spleen or has had risk of developing bacterial infection, they should be given especially pneumococcal and HIV vaccines. And last but not the least, the vaccination of close contacts. The close contacts, as I told, they include healthcare professionals also. Healthcare professionals doesn't only mean the doctors, they mean especially the staff who take care of patients on a day-to-day basis and who are less likely to be practicing universal precautions. So they should be, and maybe at administrator level or health manager level, we need to make a vaccine policy for health staff. So apart from antibiotic policy or other infection control policy, we should need to have a occupational health or vaccine policy for staff, which will not only help the staff, which will also help the key patients like these immunocompromised patients. So all age and exposure appropriate vaccines should be given. If the patient is an under 5 child, so all the primary immunizations and the boosters. If there is no previous vaccination history, we need to follow the delayed guideline. Delays vaccination guidelines are there. Say for example, for BCG, the vaccination can be given till 1 year. For DPT, it can be given till 7 years. Beyond that, it is not useful. Then we need to switch over to TD. And if our patient has never received a acellular pertussis vaccine, then the patient needs to be given, the person or the contact needs to be given acellular vaccine singly. They are usually available in combinations. Special precaution. So live vaccine like rotavirus, which is a live oral vaccine. So the people who are in contact with the patient who have been given live rotavirus vaccine, especially the small kids, we need to wash our hands so that we don't infect ourselves and then infect someone else. Right? So whenever a doctor or a manager is planning or making a policy or on a day-to-day basis during clinical interaction is planning to or thinking of giving vaccines to the patient, they should ask these kind of questions like, say for example, should adults aged more than 19 years who are or will be immunodeficient in future because of the disease or the therapy should receive 2 doses of recombinant zoster vaccine. So this zoster vaccine, we can replace it with any other vaccine and then try to ask further questions, sub questions like, is it this problem of clinical significance? Say for example, out of every 100 patients of that cancer or patients of cancer receiving a particular therapy, what proportion of them are going to suffer from herpes zoster? So how frequent herpes zoster or chickenpox is in that community? Or how substantial are the desirable anticipative? So how effective is the vaccine? How much side effect the vaccine may have? How much is the harm versus the cost? So safety versus efficacy. What is the effectiveness of the vaccine? So we had a talk on grade in the morning, Dr. Saibal Das was talking about that. So as a clinician, we need to look on that. We have resources about, I just talked about the WHO position papers, which reports the grade of particular vaccination. So that was the clinical perspective. The patient perspective. So when we are talking about this, we are thinking of clinical and the research perspective. So the value and judgment, which is the third part of the evidence-based healthcare pillar. So does the target population really feel the need? So the target population means the patients, we have patient societies, we have patient consumer groups. So they often help in making good policies. So we need to see whether the acceptability is good or bad. Acceptability is really what kind of factors are influencing the acceptability and other parameters. So we need to, whenever as a doctor, as a manager, these kind of questions should be there. So that was all from my side. I'm really thankful for the organizations, everybody, that they took time to call me up here.
Thank you, communicable disease. So this maybe after a few years we will get clear-cut guideline as well as other things also. So right now we are in a gray area and as he discussed, so we have to follow guidelines from other countries where it is already existing. In a few years, maybe we will get our guideline also. In due course of time, we will follow and we will try to do whatever the best possible for the patients suffering from cancer. So thank you, Sanjeev. Very nice. Nicely presented all those aspects of vaccines in cancer patients. Thank you. Any questions, please?
Thank you, sir. The session was incredibly rich in informative content. Now, it's time to honor our distinguished speaker. I would like to request our chairperson, Professor Dr. Sanjeev Kumar sir, Dr. Dinesh Kumar sir, and Dr. Ridu Kumar sir to please felicitate our speaker. Please come forward, sir. To felicitate our speaker, Dr. Alok Ranjan sir, Dr. Sanjeev Kumar sir. Now I request Professor Dr. Dinesh Kumar Sinha sir to kindly felicitate our chairperson, Dr. Sanjay Kumar sir. Now I request Professor Dr. Sanjay Kumar sir to kindly felicitate Dr. Dinesh Kumar sir. Now I request Professor Dr. Dinesh Kumar sir and Professor Dr. Sanjay Kumar sir to felicitate our Dr. Ridu Kumar Sharma sir. Thank you so much, sir. Our heartfelt gratitude extend to our esteemed chairperson and speaker. Thank you, sir. Our last segment of the day is the oration of Professor Dr. S.N.P. Sinha, inaugural oration of SPI Con, where we are privileged to listen to a nourishing pharmacological brilliance with enriching narrative and enduring positivity. Former HOD, Department of Pharmacology, and a very well-known medical fertility, Dr. Professor R.N. Sharma, sir. Please come on the stage. Oh, shit. I request Professor Dr. Ranjit Guha, sir, Principal IGIMS Patna, to come on the stage. Professor Dr. Lalit Mohan, sir, Professor Department of Pharmacology, IGIMS. Professor Dr. Kesav Kumar Sinha, sir, Associate Professor, Department of Pharmacology, PMCH Patna, and Honorable Member of Affiliation and New Teaching Program Committee of Aryabhat Knowledge University, Patna.
And privileged to share the dais with such a person of towering stature, who is none other than Professor R.N. Sharma sir, who can be considered also as teacher of teachers, and many of his students are now going to superannuate. Regarding R.N. Sharma sir, I would like to mention specially that I am not going to his professional career, academic credentials and all these things, but those whoever came in contact with sir due to some reason or other, all will agree that he is an evergreen person, very jolly person, though having a vast experience and vast knowledge of pharmacology, and as a teacher, his way of taking the class, making it attractive, meaningful, and effective to the students, and starting the class and ending the class with clear-cut take-home messages. And I think Lawrence Clinical Pharmacology, those who have studied, R.N. Sharma sir can be also considered as our Indian Lawrence. I have attended his class also in some college. So I have deep regards for this person who is very senior to me, but we are so close friend and so fast friend that he never allowed me to feel so. But I have got really deep respect, regards for him. So to elaborate little further about his academic credentials and professional career, I hand over the mic to one of my co-chairperson, Professor Keshavji. Sir, please.
I want to let you know that he was the former HOD and of Department of Pharmacology in Patna Medical College. He took VRS and moved on to R.D. Gardi College in Ujjain. There also he took the chair of HOD. Then finally to Narayan Medical College, Sasaram. He was HOD there also. And now he wants to take time off from this academic spree of becoming HODs in different medical colleges. To top up this, he was treasurer in IPS for a very long time, and when he moved out, he gave an asset, unbelievable asset to IPS, which is still remembered by many people. And that is all I would like to say. With a top up that he has been my head also, and the oration is in the name of a person who was my examiner, one of my examiners. So I have always been under pressure and always been under the aura of these people and never really wanted to speak out much when they are around. And this is one occasion. Now with this, I would like to invite Professor Dr. R.N. Sharma for the oration.
A few left, and out of them, so many are my students. All brilliant students, let us repeat our class again. Two stories, small stories, and one parallel story. I will tell you that will be helpful to our career. Someday I have read that a doctor was traveling from London to Birmingham. On way he was brought, he stayed somewhere to exchange his horse from the horse cart for some rest. When he stayed there, he was brought a patient there that was of Anasarca. There was breathlessness. There was a rumor that a big doctor from London is going to stay for few hours here. So that patient was brought to him, and on examination, he was a cardiologist. So on examination, he declared she is suffering from congestive cardiac failure and she will not survive. And he then went to Birmingham. On his return, again he stayed at the same place. And again that patient was brought to him. And the patient was almost all right. Then he wanted to know how she became so. He was taught that a village lady gave her some leaves, and after that she became all right. Then he collected the leaf and he brought it to London and then made a research. His followers also worked with him for several years. Then the drug came, digoxin. That leaf was Digitalis purpura, and the doctor was William Withering. So we talk about William Withering. He wrote that a poison in a small doses are a drug, and a drug in too large doses are always a poison. So taking precaution in pharmacology, let us learn that all the bigger research have gradually come. ये इतना नोटिस और फॉलो करने से कोई रिसर्च नहीं आया है, सब ड्रग ऐसे ही निकला है. और यूरिया ब्रह्मचारी, आपके हिंदुस्तान के डॉक्टर थे ब्रह्मचारी, वो निकाले, काला जर के लिए वो अचूक दवा निकली. That is known as, after his name, Uriya Brahmachari. Another small story to follow you, I am giving you, that is written in Lawrence book of pharmacology, that a girl aged about 17 years, it is a story of 1925. A girl aged about 17 or 18 years, suffered from generalized weakness. She was brought to a neurologist. Doctor finding no any cardinal sign declared nothing to worry and gave some placebo. Her weakness continued and she was unable to move and she suffered from double vision. So she was brought to an eye surgeon. He prescribed a prism and she became all right, but her weakness continued. Again she was sent to the same neurologist. Finding nothing abnormal, doctor declared her to be suffering from hysteria and asked as to what was in her mind. She clearly defines nothing, simply anxiety over my symptoms. The doctor scolded the girl and said, "My dear child, I am not a perfect fool," and showed her out. She was very much ashamed. 2 years lapsed. Her boyfriend was a medical fiance, and she became so weak that she was unable to turn up in her bed. There was a nurse. She was assisting him for physiotherapy, and her boyfriend experimented so many things. 2 years she remained ill. She was not known about what disease she suffers from. In 1927, myasthenia gravis was identified and there was no known drug for it. So she was given so many liver extracts. Previously in the beginning only extracts we are giving. कभी लीवर का एक्सट्रैक्ट दिया, कभी इंटेस्टाइन का एक्सट्रैक्ट दिया, ये सब एक्सट्रैक्ट इंजेक्ट करते थे, यही मेडिकल थेरेपी होता था. So many injections. One day her boyfriend came with a new drug and asked her, "I have to try it on you." तो लड़की जो लिखती है अपना, that is a pathetic language. वो लाइन हमको आज भी याद है. "Oh bother, another injection, another false hope." With indifference in her mind, she ultimately surrendered to the injections. वो इंजेक्शन बॉयफ्रेंड उसको दिया. Soon after that injection, she was able to raise her hand with a jerk. So she raised her hand, then her another hand, then her leg. For 10 years she remained in bed, unable to turn up, and she stood up immediately after the injection was over. So both of them danced together round the carpet several times, but some people said, no, take rest. And she writes, "Since then I have never been separated." The drug was then neostigmine. So myasthenia gravis, how it was identified and how the drug was selected for it. So a story makes a history. And these two histories are written in textbook which I have read. In India, English Empire was there. और उससे पहले क्या इलाज होता था जब अंग्रेज यहाँ नहीं आए थे? सोच सकते हैं. तो वैद्यराज का ट्रीटमेंट होता रहा होगा. तो श्लोक पढ़ते हैं हम लोग आजकल. नेवर माइंड, chairpersons also take in entertainment कि वैद्यराज नमस्तुभ्यम जमराज सहोदरम, कि वैद्यराज आपको हम प्रणाम करते हैं, आप जमराज के सहोदर भाई हैं. जमराज हरते प्राणं वैद्य प्राणं धनानि च, कि जमराज तो खाली प्राणे लेता है, अब वैद्यराज प्राण भी लेता है, धन भी लेता है. तो दोनों तरह से तो ये श्लोक बड़ा प्रिवलेंट हुआ. हमारे ज़माने में। जहाँ वैद्यराज को देखते थे तो ये श्लोक हम लोग हाथ जोड़ के पढ़ने लगते थे, हैं। तो वो अंग्रेज़ के ज़माने में, उससे पहले जो हमारे हुए, तो नाम ऐसे भी बोलते थे जो पटना मेडिकल कॉलेज से पढ़े हैं। तो SNP सिन्हा जिनके बारे में जो ऑरेशन हो रहा है, तो वो बराबर चरक और सुश्रुत, अपने हॉस्टल का नाम भी वही रख दिया था, चरक और सुश्रुता। तो सुश्रुत और चरक में कौन फिजिशियन था, कौन सर्जन था? एक फिजिशियन था, एक सर्जन था। तो चरक फिजिशियन था और सुश्रुत सर्जन था। और वो सर्जरी अपने नहीं करता था, वो बगल के हजाम को बुलाता था, उसका जो सर विपन होता था उसी से सब चीज फर करवाता था। तो सर्जन को बार बार भी बोलिएगा तो कोई बात नहीं, वो बड़ा प्राउड फील करेगा सर्जन की सही बात बोल रहा है कि उनका ओरिजिन बार्बर है। तो चरक और सुश्रुता हम लोगों के हिंदू साइंस के थे, जो सब दिन से थे। और रावण के जवान में सुखेन वैद्य था, जो सजीवन बूटी लाया था। ये सब हिस्ट्री है, हिस्ट्री की तरह सुनिए समझिए। हम लोगों का वेस्टर्न साइंस जो हुआ, तब उस समय हिपोक्रेट आया, जिसको आज भी हिपोक्रेटिक एज ऑफ साइंस बोलते हैं। उसका फोटो भी सब कॉलेज में हिस्ट्री में रखा हुआ रहता है। तो वेस्टर्न साइंस हम लोगों पर सुपरसीड किया अंग्रेज के ज़माने से। और हिपोक्रेटिक ओथ आज भी आप डॉक्टर बनते हैं, लेते हैं, हिपोक्रेटिक ओथ लेते हैं। तो पहले ही फार्माकोलॉजी नहीं था, कुछ नहीं था, ऐसे ही पढ़ा दिया कैसे पट्टी बांधेंगे, कैसे क्या करेंगे, और मेडिकल स्कूल का लाइसेंस दे दिया, वो डॉक्टर हो गया, बहुत सीरियस डॉक्टर हुआ। आपके यहाँ पहला डॉक्टर कौन हुआ, कहाँ से हुआ, किस स्टेट से हुआ? तो इट वाज कोलकाता। कहा है कि अंग्रेज़ों की राजधानी कोलकाता ही थी। और अंग्रेज का लॉर्ड विलियम बेंटिक करके यहाँ गवर्नर हुआ था, जिसने मेडिकल साइंस का टीचिंग स्टार्ट किया। ही ओपन एन स्कूल एट कोलकाता। और बहुत से लोग उसमें सीखने के लिए जानते थे, तो अंग्रेज सब मार के भगा देता था कि नहीं नहीं, तुमको अंग्रेजी नहीं आते हो, बंगला बोले तो कैसे होगा। तो कुछ लोगों को रखा उसमें। फर्स्ट MBBS जिसका नाम था मधुसूदन गुप्ता, फर्स्ट MBBS स्टूडेंट निकला था। और उसी समय एक अंग्रेज को फार्माकोलॉजी का टीचर बनाया, मेडिसिन का टीचर बनाया। दैट हिस्ट्री इज देयर कि पटना मेडिकल कॉलेज में फार्माकोलॉजी डिपार्टमेंट में जाइएगा तो देखिएगा एक सीरीज ऑफ फोटो लगा हुआ है। दैट गिव्स द हिस्ट्री कि हर मेडिकल मैन को फार्माकोलॉजी पढ़ना पड़ता था, चाहे वो मेडिसिन के हों, चाहे ऑप्स गायनी के हों, चाहे किसी भी स्पेशलिटी के हों, तो उनको फार्माकोलॉजी में, बिकॉज दे ऑल हैव टू डिस्पेंस सम ड्रग। पहले इतना दवा की कंपनी नहीं थी, तो मोस्ट ऑफ द ड्रग जो चाहते थे वो डिस्पेंस करना होता था। एंड द लास्ट प्रोफेसर हु डिस्पेंस द ड्रग वाज मोहिब अहमद, जो हमसे पहले पटना मेडिकल कॉलेज का हेड हो करके, नाउ ही इज़ नो मोर। तो वही डिस्पेंस भी करते थे और इलाज भी, कुछ अपना अर्निंग भी होता था, लेकिन पढ़ाते थे, वो डिस्पेंस करना सबको सिखाते थे। एंड दिस डिस्पेंस से ही डिस्पेंसरी बना है। दैट डिस्पेंसिंग वाज स्टार्टेड फ्रॉम वेस्ट बंगाल, कोलकाता। Calcutta Medical College was started in 1835 और 3 ही मेडिकल कॉलेज बना था। वो तीसरा कलकत्ता जो सबसे लास्ट में बना, और सबसे पहले गोवा मेडिकल कॉलेज बना था यहाँ, और उसके बाद पौंडीचेरी बना था। Now come to the Indian pharmacology. This is a story of medical college and medical teaching. The pharmacology, Indian pharmacology starts from 1921, जो really हुआ। And अभी डिस्कस हुआ था जिसमें कर्नल रामनाथ चोपड़ा, जरा सा फोटो निकाल लीजिए, कर्नल रामनाथ चोपड़ा, फार्माकोलॉजी आर्यन चोपड़ा। और ऊपर ऊपर जाइए, हाँ देखें नीचे जाइए ना, ये क्या है, सबसे पहले ना, और यही पीछे है। आर्यन चोपड़ा, उस जमाने में केमिकल फार्माकोलॉजी 3 तरह से पढ़ाई होती थी, खाली केमिस्ट्री पढ़ाता था लोग, इसका स्ट्रक्चर यह है। तो उस समय जैसे फेरस सल्फेट पढ़ाया तो उसमें क्या पढ़ना है एक्स्ट्रा, लेकिन हमारे प्रोफेसर हमको आयरन का 50 गो कंपोजिशन पढ़ाते थे, अब उतना याद करना मुश्किल था। तो फार्माकोलॉजी में हनुमान चालीसा पढ़ के जाते थे कि किसी तरह से निकल जाए। अब प्रोफेसर जी आचार्य हमारा एग्जामिनर टीचर सब चीज़ था, उसके सामने तो हवा भी सांस में 58% जाता था, ऐसा था। दैट वाज ए टेरर। तो कैसे पढ़ाई हो, क्या सवाल पूछा, और गलती से मॉर्फिन का, मॉर्फिन बड़ा पढ़ाते भी थे पूछते भी थे, तो मॉर्फिन का डोज अगर आप बोल दिया 20 मिलीग्राम तो गए आप काम से, उस साल तो नहीं पास करना है। हाँ, अगर आप बोला 1/4 ग्रेन तो बहुत खुश हो जाता है। और उसके सामने किसी तरह से टेट्रासाइक्लिन का क्वेश्चन बहुत इम्पोर्टेंट था। आज जितना डिस्कशन हुआ, एंटीबायोटिक हुआ, आपने टेट्रासाइक्लिन सुना? दिस इज नाउ अबंडन ड्रग, बट recapitulate you, a few tetracyclines are still highly effective. तो whenever you used to tetracycline, काहे टेट्रासाइक्लिन, 4 साइक्लिन बोलना पड़ता था। अगर गलती से उसमें ऑरियोमाइसिन आपने बोल दिया तो तुरंत पूछता कि हु इज डिस्कवरर। अगर आप सुब्बा राव बोल दिया तो उसके बाद आपको कोई रोक नहीं सकता, यू विल गेट मिनिमम 73% मार्क्स, 75 नहीं देता है, वो 75 वाज इम्पॉसिबल फ्रॉम हिम, लेकिन सुब्बा राव बोल दिया तो 73% होना है। सुब्बा राव कौन थे? ही वाज वन ऑफ द साइंटिस्ट फ्रॉम इंडिया जो मेथोट्रेक्सेट मॉलिक्यूल निकाला। ही वाज नॉट ए फार्माकोलॉजी मैन, he was a microbiologist and he was interested here. उसी तरह से जो कर्नल रामनाथ चोपड़ा जो सबसे पहले हुए, तो 1920 में वो फार्माकोलॉजी को एक तरह से काम करके इंडिया में काम करने आए, और फार्माकोलॉजी में काम किया तो ही डिड ओनली इंडिजिनस वर्क। देयर इज अ सीरीज ऑफ बुक इन पटना मेडिकल कॉलेज लाइब्रेरी आई हैड परचेस्ड। वो टोटल जो आदमी काम करना चाहते हैं इंडिजिनस मेडिसिन तो बहुत बनता है ना, और बहुत बना सकते हैं, मैनी फील्ड इज लेफ्ट देयर। तो रामनाथ चोपड़ा वैसा सब मेडिसिनल प्लांट पर सेवरल सीरीज ऑफ बुक्स दिए हुए। थोड़ा सा नोबेल प्राइज विनर फार्माकोलॉजिस्ट, नॉट फ्रॉम इंडिया बट ए फ्यू साइंटिस्ट, I simply name them. जॉन वेन पहला नोबेल प्राइज विनर था, जेम्स ब्लैक भी था, और एक एलियन था, और 2-3 और हैं जो हम नहीं बतावेंगे नाम। वो फार्माकोलॉजी से ही नोबेल प्राइज विनर हुए। तो नॉट गारंटीड, सम ऑफ यू ऑल्सो मे बी ये चांस कि कुछ मॉलिक्यूल ऐसा आपसे निकल जाए, और ये मॉलिक्यूल अकेले आप नहीं निकाल सकते, तो इसके लिए देयर शुड बी ए कोलैबोरेशन। तो इस सोसाइटी के माध्यम से, अपने जनरल सेक्रेटरी और दीक्षित साहब के माध्यम से, हम आप सब की तरफ से एक रिक्वेस्ट गवर्नमेंट ऑफ बिहार को करना चाहते हैं कि एक रिसर्च यूनिट अलग से खुलना चाहिए था बिहार में। गुहा साहब, प्रिंसिपल साहब वेरी मच क्लोज टू द गवर्नमेंट, तो ये भी कोशिश करें कि एक रिसर्च यूनिट खुले जहां इन कोलैबोरेशन विद केमिस्ट, फार्मास्यूटिकल केमिस्ट, फार्माकोलॉजी पर्सन और माइक्रोबायोलॉजिस्ट सब मिल करके कुछ मॉलिक्यूल खोजें कि ऐसा मेथोट्रेक्सेट और यूरिया ब्रह्मचारी के बाद कोई ऐसा ड्रग नहीं है जो आपने निकाला और आप ही के नाम से चल रहा है. ऑल्सो CDRI, ICMR, दे आर इन फुल प्रोसेस एंड दे आर डूइंग इट. आपके यहाँ भी एक रिसर्च सेंटर है RMRI, लेकिन वो इलाज करे कि जांच करे कि रिसर्च करे ऐसा नहीं है. तो ही इज़ ऑल्सो बॉदर्ड. तो बिहार में तो जितने बड़े बड़े आए सब कंफ्यूज हो करके चले गए, सीधा कोई नहीं आया. एक बार हमारे मेडिकल कॉलेज में इंस्पेक्शन करने के लिए आए अटेंडेंस, तो हमारे जो कमिश्नर थे वो अपने पहुंच गए. PMCH इंस्पेक्शन करना है, तो हमारे डिपार्टमेंट का इंस्पेक्शन कर लिए और बगल के डिपार्टमेंट के इंस्पेक्शन में गए. तो बगल वाले डिपार्टमेंट वाली इतना रजिस्टर न उनको दिखाए, कभी इधर से पलट के उधर, उधर से पलट के उधर. 5 मिनट उनका माथा, IAS ऑफिसर का अगर 5 मिनट माथा आप खा गए तो उसके बाद उसके माथा में बचता ही नहीं है कुछ. हाँ, उधर से आप हमसे वो क्वेरी किया था कि फलना आदमी छुट्टी में है, तो आपने एप्लीकेशन उसका नहीं दिया. तो हम कहा कि हम दिखला देते हैं, हमको कुछ करना पड़ा. तो हम ले करके एप्लीकेशन खड़े हैं, लेकिन उधर से वो इतना कन्फ्यूजन में न निकला कि वो सीधा गाड़ी में बैठा, 2-4 को लिए हुए चला गया. तो हम उस प्रोफेसर को पूछा कि भाई क्या तुम कर दिए कि वो इतना कन्फ्यूजन हो गया है? तो तुम तो पहले से बड़ा साफ सुथरा बैठे हुए थे कि आज इंस्पेक्शन है. तो वो बाद में बताया कि सर ऐसे किया ऐसे किया. तो बिहार की नौकरी भी ऐसी ही है. यहाँ आए तो गुहा साहब अनुभव करते होंगे. हाँ, यहाँ आने के बाद जाने के समय में 100% कन्फ्यूजन मिलता है, नथिंग मोर. लेकिन एक कन्फ्यूजन क्लियर कर देते हैं कि एक रिसर्च सेंटर जो हमारा यंगर जनरेशन आता है, हु शुड बी एक्सक्लूसिवली पोस्टेड फॉर रिसर्च वर्क एंड लेट अस मेक ए न्यू मॉलिक्यूल. अगर हमारे यहाँ से नया मॉलिक्यूल निकलता है तो और अच्छी बात है. तो 2 ही आदमी का हम नाम लेते हैं. एक नाम जो हरगोविंद खुराना का सब लोग लेते हैं, लेकिन आई डोंट फील कि हरगोविंद खुराना नेशनलिस्ट थे. कहा कि उनको जब DNA का काम किए, गवर्नमेंट ऑफ इंडिया उनको अवार्ड दिया तो अवार्ड लौटा दिए. तो जब हमारे इंडिया का अवार्ड लौटा दिए तो हम उनको कैसे समझे कि वो हमारे इंडियन हैं, और वैसा नाम हम उनको रिस्पेक्टफुली नहीं लेते हैं. ही हैज़ डन समथिंग एंड कभी वो हिस्ट्री में है तो कभी हम लोग हिस्ट्री में होंगे, तो फिर आगे जाके आप लोग हिस्ट्री बनिएगा. तो हिस्ट्री चलता रहे, ऐसे ही चलता रहे, भली डिक्ट्री भी हो जाए, हम लोग खा पी के बुलंद होकर के सब एक दूसरे को आशीर्वाद देते हुए चले जाए. थैंक यू वेरी मच.
आज सर I know personally from sir to from MBBS time, that time सर का 2 वहाँ पर स्टूडेंट था. इतना सेवा किया तो लगा कि हम प्रोफेसर बनना जरूरी है. आज न कल प्रोफेसर बनना बहुत जरूरी है. दोनों सर का दम, एक पान पड़ा के एक खत्म हो, दूसरा लेके आ जाता था. अब याद नहीं है कि सर को याद होगा कौन सा वो स्टूडेंट था दिल्ली में कुछ कर रहा था सर का उस समय. ठीक, थैंक यू सर फॉर योर ऑडिशन, ब्यूटीफुल ऑडिशन.
Just to conclude, 1 second only about Arun Sharma sir. This is the quality I was just telling in my introductory lecture, that this storytelling way, the things sir told everything. So it was so absorbing, mesmerizing and enthralling. Everybody was really enjoyed the thing. So this enjoyment is important through your teaching and storytelling. And sir, what told today, this is the way, actually this is the typical Arun Sharma sir's teaching way. So that's what I like so much, so much, and that is the thing he is known for. So this is very important, because now in the era of this competency-based medical education, one item is storytelling. Storytelling has been incorporated, and sir is doing that role play storytelling. Sir is doing that since beginning, and he has not changed. He is continuing that. So that's why my respect, deepest respect and regard for sir always. is there. We are lucky that we have heard sir after long, because I wish I could hear from this type of teachers. Now we can occasionally interact and we can learn many more things. This is the thing. So thank you, sir. Keep us blessed, blessings. Continue to give your blessings on us, and I'm taken your message, sir. And we are having a multidisciplinary research unit. Where our director, sir, is strengthening all these things so that as real scientists are also there. They appointed 14 scientists working. So they are all in the target of inventing something new, so that at least Bihar came into the international forefront, international global map. Thank you, sir, for your advice. It's
Request our Joint Organizing Secretary, Professor Dr. Hitesh Mishra, sir, Additional Professor, Department of Pharmacology, IGIMS, to come over the stage and read the scroll.
Inviting me to read out the scroll there. And regarding, this is the Professor S.N.P. Sinha inaugural oration of ASPI. Okay, regarding Professor Arun Sharma sir. So he started the voyage of exemplary contribution and resolute dedication. He stands as a guiding light in the realm of pharmacology, leaving an indelible mark on the canvas of medical science. His transformative influences resonates through the corridors of knowledge, enriching both academy and the healthcare. Sir has embarked on his academic odyssey at the SKMC Muzaffarpur, a journey that spanned 4 decades and witnessed his distinguished services there. The corridors of PMCH and RD Gadi Medical College Ujjain and Narayan Medical College Hospital Sasaram were fortunate to be illuminated by his erudition and visionary leadership. However, it is within the walls of PMCH Patna that Professor Sharma's legacy shines with exceptional brilliance. His engaging teaching style, akin to weaving intricate tales, transforms complex and pharmacological concepts into captivating narratives there. And in the ever evolving landscape of pharmacology, Professor Sharma's wisdom and dedication have been instrumental. His impact on patient care, research, and education is profound. His narratives of knowledge, jolly spirit, now this is jolly spirit what we had seen there, and radiant positivity continue to guide and inspire us. Thank you, sir. So regarding Professor S.N.P. Sinha, sir, so Sinha, sir, was a true luminary in the realm of the medical science and education. Born on July 12, 1936, his journey through the annals of medical history has left an indelible mark that continues to inspire generations. Professor Sinha's academic voyage commenced at PMCH, where he embarked on a path that would reshape medical education and redefine research. A visionary educator, Professor Sinha's tenure as the professor and head of the department and his alma mater nurtured generations of medical minds. His leadership as principal of the institution further solidified his commitment to shaping the future of medical practice. And regarding this is the last para. Professor Sinha's dedication transcended boundaries, evident in his advocacy through media and his involvement with institutions like Mahavir Cancer Institute. His legacy remains a testament to the symbiotic relationship between medical science and the compassionate education. So, thank you, sir.
Now it's time to honor our distinguished orator with a felicitation. I request our respectable chairperson, Professor Dr. Ranjit Goa sir, Professor Dr. Lalit Mohan sir, Professor Dr. Keshav Kumar Sinha sir, to kindly felicitate our auditor, Professor Dr. R.N. Sharma sir. I request Professor Dr. Harya Dikshit sir to please come on a stage and do the honor. Now it's time to honor our respectable respectable chairperson. I would like to request Professor Dr. Keshav Kumar Sinha sir to felicitate Professor Dr. Ranjit Gua sir. I request Professor Dr. Keshav Kumar Sinha sir to facilitate Professor Dr. Lalit Mohan sir. I request our principal, Professor Dr. Ranjit Gua sir, to felicitate Professor Dr. Keshav Kumar Sinha sir.
बहुत धन्यवाद सबों को। हम समझते हैं कि शर्मा सर का ये जादूगरी ही है कि खाने के लोग डाइनिंग हॉल में नहीं गए हैं, इतने लोग, तो इतने तो इनके भक्त है ही हैं। ये बहुत बड़ा एक ये है कि लास्ट एकेडमिक प्रोग्राम में ऑडियंस बहुत कम होते हैं, 2 या 4 इस तरह से, लेकिन ये सर आपकी यानी अभी भी पढ़ाने की का जो शौक़ है, जो पोस्ट रिटायरमेंट अभी भी सर किसी मेडिकल कॉलेज में जाके पढ़ाते हैं सप्ताह में 1 दिन। ये इनकी हॉबी है, इनकी आदत है, और हैबिट को अगर एज को हथौड़ा मार दो तो हैबिट बच ही जाएगा, वो चलता रहेगा, फिर तो रिवाइव कर जाएगा। तो ये इनकी आदत है, और पैशन जिसको कहते हैं ना, आदत क्या पैशन है कि पढ़ाना है। और कैसे पढ़ाना है? स्टोरी टेलिंग। ये इनका ये क्वालिटी सब में नहीं हो सकता है, ये सहज क्वालिटी है। आप इनसे गप करेंगे, घंटों गप कर सकते हैं, आप बोर नहीं हो सकते हैं। सब्जेक्ट पे बात करो तब भी, न सब्जेक्ट पे बात करो, ऐसे वैसे जैसे जैसे सर, ऐसे वैसे जैसे सर, कुछ भी आपको सुनाते रहेंगे और बहुत ही आप तन्मयता से सुनते रहेंगे, ध्यान के साथ, और आप बोर नहीं होंगे। ये इनकी क्वालिटी है, और इस उम्र में स्टिल ही इज यंग। भगवान करे आप और अच्छे स्वस्थ रहें, सुखी रहें, और लंबी आयु आपको भगवान दे, ये कामना है। और चूंकि बहुत लोगों को भूख लग गई होगी, बहुतों का अदर असाइनमेंट भी होगा, तो एक वैलिडिटी होगा, वो एक प्लान्ड है कि भाई बच्चों को सर्टिफिकेट देना है ये वो। लेकिन सब इतने लोग आए, चाहे वो वर्कशॉप में हो, चाहे वो कॉन्फ्रेंस में हो 18 तारीख को, या आज, बहुत सारी कठिनाइयाँ आप लोगों ने झेली भी होंगी, कहीं फुटफॉल होंगे, कई जगह आपको लगा कि थोड़ा सा और अच्छा रहता अगर ऐसा नहीं होता। तो जो कुछ भी गड़बड़ियाँ हुई हैं वो उसको मैं सिरोधार्य करता हूँ, उसके लिए माफ़ी मांगता हूँ। और अच्छा, वो भी बोलते हैं, जो भी गड़बड़ी हुई है उसका श्रेय मैं लेता हूँ, लेकिन जितने भी अच्छे काम किए हैं, चाहे वो एंकरिंग हो या बाकी और सब, ये श्रेय सारे वॉलेंटियर्स और सारे ऑर्गेनाइजिंग कमेटी को मिलता है। तो इसके लिए तालियां तो बननी चाहिए। तो बोथ एंकर्स, खुशबू और सुचित्रा, ललित ऑर्गेनाइजिंग सेक्रेटरी, हितेश, केशव, रानी इंदिरा मैडम, रंजीत गुहा मैडम, इंदू मैडम, जितने भी ऑर्गेनाइजिंग कमेटी के ऑफिस बेयर हैं, आशा, सब लोगों को आपके सहयोग के लिए बहुत बहुत धन्यवाद। आपके ही सौजन्य से ये हुआ है। अगर वो आपका सहयोग नहीं मिलता, एक्टिव पार्टिसिपेशन नहीं मिलता, हर जगह आपका सहयोग मिला है, उसके लिए मैं तहे दिल से आप लोगों का शुक्रगुजार हूँ, और आप लोगों को शुभकामना भी कि आगे जब भी कुछ हम लोग प्रोग्राम करें तो उसको करें। याद होगा आशा 2011 का सोपी का कॉन्फ्रेंस किन परिस्थितियों में हमने किया था। मैं आईजीएमएस में ज्वाइन कर चुका था, नालंदा मेडिकल कॉलेज में सोपी को एक्सेप्ट कर लिया था, बहुत सारा हर्डल हुआ, हमने किया, और वो अकेले नहीं हो सकता था। केशव की मुरली बजी, केशव की मुरली इसलिए हमारे लिए बहुत एक सौभाग्य का प्रतीक होता है ना। केशव आ गया, यानी ओम नमो भगवते वासुदेवाय, केशव आ गया, उसकी मुरली बज गई, शंखनाद हो गया और अच्छे से सब विघ्नहर्ता की कृपा हुई कि सब कुछ ठीक से हो गया। तो इसके लिए एकेडमिकली हम कह सकते हैं इस कॉन्फ्रेंस को बहुत ही सक्सेसफुल हुआ। एसपीआई का जो जन्म हुआ है, विजन हमारा यही था कि ये एक ऐसा ऑर्गेनाइजेशन बने जो डिपार्टमेंट ऑफ फार्माकोलॉजी का डेवलपमेंट तो करे, लेकिन एट द सेम टाइम विद द कोऑपरेशन ऑफ अदर सब्जेक्ट्स। मान लीजिए मेडिसिन है, ऑन्कोलॉजी है, कम्युनिटी मेडिसिन है, तो एक पूरा का पूरा कैनवास, आपका पूरा आकाश मंडल आपके सामने रहेगा और आप उसमें कोलैबोरेट कर सकें, कोऑपरेट कर सकते हैं, तब जाके आप कुछ अच्छी चीज़ दे सकते हैं। अगर नहीं, आप मल्टी डिसिप्लिनरी इंटरेक्शन नहीं करेंगे तो फार्माकोलॉजिस्ट का किताब में ही रह जाएगा, वो गैप रह जाएगा। दैट्स वाई आई हैव चूजन मेनी टॉपिक्स। अब कैंसर में वैक्सीनेशन क्या है, वैक्सीनेशन के हर जगह हो रहा है, देखिए एक नया टॉपिक है, हमको वो जानना है कि क्या हम कर सकते हैं। केवल बीसीजी ही के डाल के हम ब्लैडर कार्सिनोमा को ठीक कर सकते हैं, ऐसा नहीं, नई चीज़ आना चाहिए, एक इंस्पायरेशन मिलेगा। आज के जितने भी टॉपिक्स रहे हैं वो आपको दिमाग में डालेंगे, कुछ बातें आएंगी और उस पर आप रिसर्च कर सकते हैं। फॉर एग्जांपल डॉक्टर आशुतोष विश्वास ने कम्युनिटी इन्वायरमेंट की बात की थी। मैंने ऑलरेडी एक पीएचडी स्टूडेंट को अपने अंडर में इको फार्माकोविजिलेंस पर यहाँ दिया है टॉपिक। डाइवर्सिफाइड हमारा काम हुआ है, मॉलिकुलर पर भी काम हो रहा है, इको फार्माकोविजिलेंस पर भी काम हो रहा है। ये सब आप अकेले नहीं कर सकते हैं। इको फार्माकोविजिलेंस करना है तो कम्युनिटी में जाना होगा, आपको फार्मास्यूटिकल इंस्टीट्यूशन लाइक नाइपर से आपको सहयोग लेना पड़ेगा, क्योंकि असेसमेंट हमारे पास नहीं है, हम नहीं कर सकते हैं। और आप डाटा अपना नहीं दे सकते हैं। बिहार का क्या स्थिति है, पटना मेडिकल कॉलेज के बाहर गोविंद मित्रा रोड में आप देख लीजिए, दवाओं का एक पूरा अंबार लगा हुआ है, वो सब जमीन में जा रहा है और वो पानी आपको पॉल्यूट करके मिल रहा है। तो देयर आर मेनी एस्पेक्ट। तो हम समझते हैं कि सहयोग, सबों का सहयोग होगा तो कोई भी चीज़ आप पूरा कर सकते हैं, चाहे ये कॉन्फ्रेंस हो या अपना रिसर्च। बहुत ज़्यादा मैं समय ले रहा हूँ, धन्यवाद। और जैसा कि सुकल्याण ने कहा, इसका सबसे बड़ा अपॉर्चुनिटी विद्या आपके द्वारे, मैक्सिमम आपके घर पे ये एक अपॉर्चुनिटी मिला था कि आप अपना प्री पेपर प्रेजेंट कर सकते हैं, पोस्टर प्रेजेंट कर सकते हैं, एनएमसी के रिक्वायरमेंट को फुलफिल कर सकते हैं। और ये बड़ी हर्ष की बात है, 140 से ज़्यादा पेपर और ई पोस्टर्स प्रेजेंट किए गए हैं। ये बहुत बड़ी बात है, बिग अचीवमेंट, बहुत बड़ी बात है। इतने, यानी आप एक छोटा सा पहला ये कॉन्फ्रेंस हुआ है और इतने क्यों अपॉर्चुनिटी प्रोवाइड किया गया, प्लेटफॉर्म। हम लोगों को क्या चाहिए? कुछ नहीं, हम बराबर इस बात को कहते हैं, मुझे कुछ नहीं चाहिए। आप एक हेलीपैड आप यहाँ तैयार करके दे दो, बच्चे उड़ान भरेंगे। पर्पस मेरा यही है, बच्चों तुमको अपॉर्चुनिटी मिलेगी। हर लीडर को चाहिए आने वाले जनरेशन को डेवलप करना, इंस्पायर करना। लीडर ही सब कुछ लेते रहेगा तो फिर बड़ा मुश्किल हो जाता है। इसलिए हम समझते हैं कि ये बातों को ध्यान में रखेंगे और अपॉर्चुनिटी हम लोग सब एक दूसरे को दे सकते हैं। इस आशा के साथ इस प्रोग्राम को ख़त्म किया जाता है। सभी लोगों को धन्यवाद और खाना खाने के लिए चलें, बहुत लेट हो रहा है। बहुत देर आप मेरा भी भाषण सुन लिया, इसके लिए धन्यवाद।
After lunch,
हम लोग फिर
after lunch there is valedictory session there. So those who want to stay, they will please come with us for the lunch, and then we will come back here. और सब पोस्टर और सब प्राइज भी हम लोग रखे हैं, तो हाँ सर्टिफिकेट डिस्ट्रीब्यूशन भी होगा. तो those who want to be here, please remain here. Just we will go for lunch.
Start our valedictory function, prize distribution and felicitation. So first I would like to welcome our organizing chairman, Professor Dr. Hariyar Dikshit sir. Our principal sir, Professor Dr. Ranjit Guha sir. I request Ranindra Sinha ma'am, please come on the stage. Professor Dr. Arun Sharma sir. And I request our organizing secretary, Professor Dr. Lalit Mohan sir. Participant and all delegates who share their ideas, innovative research and perspective on various topics. So now the moment we have all been waiting for, we'll proceed with the prize distribution for poster presentation. So I request to all the guests here on the dais, please present the award to our winners. So the third prize goes to Srishti Shamantha for poster presentation.
Dr. Srishti Samanta, second year PG resident from Patna Medical College.
Sir, poster of rupees 1500 and certificate. And it's a tie for the third position. I request Dr. Rinki Thakur ma'am.
This prize session in this SPI is started by Dr. Hariyar Dikshit sir, poster prize. So third prize to her.
It's a tie. Third prize in Professor Hariyar Dikshit prize poster presentation goes to Dr. Rinki Thakur ma'am. Ma'am, please introduce yourself first.
Myself, Dr. Rinki Thakur, senior resident and DM Clinical Pharmacology, second year student, IJMS Patna. And the topic for my poster was, it was a case report on nimesulide-induced toxic epidermal necrolysis, still an occurrence.
She is also receiving the cash prize of rupees 1500 and certificate for her poster presentation. Now the with a cash prize of 2000 rupees and certificate.
A very good afternoon to each and everyone. I am Ambika, a PhD research scholar in the Department of Pharmacology and Toxicology in Naipar, Hajipur, and working under the supervision of Dr. Vipin Kumar Parihar, sir.
Sir, to please join us on the stage. Now the first prize for poster presentation goes to first prize with cash of 2500 and certificate.
My name is Suparas Jain. I am a student of Naipar Hajipur, Department of Biotechnology.
Yes, sir. Thank you, sir. We congratulate to all winners and all the participants for their efforts. Yes, sir. When's the valedictory ceremony?
I request our organizing chairman and organizing secretary, our principal sir, to felicitate co-organizing chairman, Professor Dr. Deepak Kumar. Sorry, he is not here. जी. Professor Dr. Indra Sinha, ma'am. Sorry, ma'am. Yeah, Professor Dr. Rani Indra Sinha, ma'am. Please clap for the ma'am. Please honor our co-organizing chairman, Professor Dr. Keshav Kumar Sinha, sir. Now I request our joint organizing secretary, Dr. Hitesh Mishra, sir, please come on stage. Now I request Dr. Manish Kumar, sir, to please come on stage for the honor. Now I request Dr. Now I request Dr. Shukalyan Saroy, please come on stage. Sorry, he is not here. Now I request Dr. Adil Ali Shakur, sir, please come on stage for an honor. Now it's time to felicitate our organizing committee. I would like to call Engineer Shailendra Kumar, Chief Technical Advisor. Please come on stage. Mohammad Margoof Ahmed sir, Scientist 1, please come on stage. Dr. Pankaj Prabhakar sir, please come on stage. Dr. Manoj Kumar sir, please come on stage. Dr. Purnendu Arya. Dr. Lalit Kumar sir. Dr. Amritanshu Sekar sir. Dr. Roshan Kumar Ranjan sir. Dr. Shazid Hamid sir. Dr. Rinki Thakur ma'am. Dr. Noor Hussain sir. Dr. Chakrapani Kumar sir, please come on stage. Dr. Amrendra Kumar Arya. Dr. Mukesh Kumar sir. Dr. Mukesh Kumar sir. Dr. Ravi Roshan sir. Dr. Neetu Pandey ma'am. Dr. Rajiv Kumar Neeraj sir. Dr. Chandini Prakash. Suchitra Kumari. Khushbu.
Shri Premnath Sharma. अच्छा volunteers. सर है volunteer का नाम
Niharika. Lovely Anand. Sri Pradeep Kumar Singh. Sri Ravindra Kumar Singh. Muhammad Sakil Ahmed. Shailesh Kumar. Kunal Kumar, Rajiv Ranjan, Jaiprakash Kumar, Mithu Kumar, Rekha Devi, Asha Devi, Muhammad Taslim, Muhammad Kaleem, Mantoos Kumar, Technical Assistant, Dheeraj Kumar, Photographer and a
फोटो कौन खींचेगा
Sambhavi Amar, our volunteer. Shambhavi. अन्वेषा, मानसी झा, रोहिणी, काव्या अंजलि, आयरा गुप्ता, अमीशा गुप्ता, अभिषेक रंजन, आकाश राज, अमीशा, प्रकाश कुमार, फराज आलम, अश्विनी, अश्विन, अक्षय, आशुतोष, डॉक्टर रवि रंजन, वॉलंटियर, he is coming, sir. डॉक्टर रवि रोशन, कुणाल भैया, शैलेश भैया, जल्दी आ जाइए। आ जाते करना है, किसको बुलाना है? कुछ बोलिएगा थोड़ा सा।
नहीं सर हो उधर से जाओ, उनको बोलो हैंड वाला माइक ला के। नाम बताए नहीं, कैसे अनाउंस करें?
Everybody, and this is the postprandial valedictory function that is being going on. जस्ट एक मिनट ही बस लेना था हमें रियली सबको, जितने बिहार के मेडिकल कॉलेजेस हैं और आउटसाइड बिहार के जितने भी मेडिकल कॉलेज जिनने पार्टिसिपेंट्स यहाँ पे भेजे हैं, तो रियली वी आर थैंकफुल टू ऑल ऑफ देम। उनके बगैर ये कॉन्फ्रेंस सक्सेसफुल हो ही नहीं सकती थी, तो इसलिए जस्ट एक वो थैंक यू वर्ड बोलना था, इसलिए आए हैं। ओके, थैंक्स ए लॉट।
Please come on stage and say a few words.
Any feedback about conference? No one?
अगर आप फार्माकोलॉजी में हैं, एक स्टूडेंट के को क्लास में पढ़ा रहे हैं, तो फीडबैक लेना ज़रूरी है। वेदर हमने जो मैसेज दिया वो आपको मिला या नहीं मिला, या हमने जो समझाने का प्रयास किया वो आप समझ पाए या नहीं समझ पाए, ये एक आदत बननी चाहिए। और बेझिझक सही बात सही जगह बोलना चाहिए। अब आप क्राउड में किसी को कुछ बोलिए, उससे कोई मतलब नहीं है। ये देखना है सही समय पर सही बात अगर बोली जाए तो उसका इम्पैक्ट कुछ और होता है, और बातें जो बोली जाए वो सही मायने में बोली जाए, सही शब्दों को इस्तेमाल करके। अगर एक ही बात को कई लहजे से कहा जा सकता है और उन लहजों में अंतर हो जाता है। आपको खाना खाना है? नहीं, ये एक एक अंदाज हो गया। आपको है आप खाएं तो नहीं नहीं नहीं। तो दोनों ये जो इस तरह का संवाद जब होता है तो किस आप भाव से पूछ रहे हैं उसका जवाब उसी भाव से आता है। तो फीडबैक लेना चाहिए, देना भी चाहिए, दोनों, तभी इम्प्रूवमेंट होता है। अगर आप फीडबैक नहीं देंगे, नहीं लेंगे, इम्प्रूवमेंट नहीं होगा। लेकिन अंत में मैं सबों को धन्यवाद करता हूँ, स्टार्टिंग फ्रॉम माई ऑर्गेनाइजिंग सेक्रेटरी ललित मोहन, और डॉक्टर जितेंद्र जी, मृगिंदर जी, मृत्युंजय जी, डॉक्टर कृष्णमूर्ति जी, हितेश, डॉक्टर विपिन परिहार जी, नाइपर डीन, डॉक्टर केशव, मुरली, जिसका मुरली के बिना हम नहीं चल सकते हैं, मंतोष, हरि जी का पार्टी जो है वो, इनके ऑडियो विजुअल के द्वारा जो कुछ भी हुआ है वो सौजन्य शैलेंद्र जी और इनके द्वारा किया गया है। हम आप सबों को भी धन्यवाद देते हैं। शकील, मनीष, मनीष बहुत, मैं जब आया मैं अकेला था, उसके बाद एक ये एक सीनियर रेजिडेंट को मैंने अपॉइंट किया, वो मनीष साइलेंटली बहुत काम किया है। इसके काम को हम कम गिनाएंगे तो बहुत कम हो जाएगा। उस समय जो इसने मुझे साथ दिया, जबकि ये रॉ था, और साथ दिया और परफेक्टली साथ दिया। हम समझते हैं कि काफ़ी अच्छा काम किया, और इसके लिए भी हम आपको ये कीप इट अप, ये तुम्हारे ग्रोथ के लिए भी फ़ायदा है। बोलना हर जगह ज़रूरी नहीं है, तो मेहनत बहुत ज़रूरी है, और पे करता है ये मेहनत। मनीष हुआ, मनोज बहुत मेहनत किया है, एनिमल हाउस बनाने में भी मेहनत किया है। मनीष की तरह ही टेक्निकल सपोर्ट एनिमल हाउस में इसने दिया हमको। इस प्रोग्राम को भी संचालित करने में बहुत मदद किया। प्रेस मीडिया का इंचार्ज भी है। आज का भी कम्युनिकेशन होना चाहिए मनोज जी, आज का क्या आप कन्वे कर रहे हैं, जिसमें RN शर्मा जी ने एक मैसेज दिया है कि रिसर्च यूनिट होना चाहिए, उस मैसेज को भी आप हाईलाइट कीजिए। और इकोनॉमिक, आशुतोष विश्वास ने जो कहा है कम्युनिटी में जो वेस्ट, बायोमेडिकल वेस्ट का जो डिस्पोजल है उसका भी आप डालें। प्रभाकर, तुमने भी मेहनत किया। मोहिब साहब, ये मरगूब जी, वेल डन। अंत में मैं यही कर सकता हूँ, वेल डन। फिर भी आपने ट्रांसपोर्ट को ठीक किया, ठीक किया आपने, हर तरह से ठीक किया। और कंग्रेचुलेसन फॉर गेटिंग ICMR प्रोजेक्ट ऑफ 40 lakhs। डॉक्टर अमरिंदर, फेलो फ्रॉम नाइपर। चक्रपाणी, तुमने भी बहुत मेहनत किया। पुणेंदु, भाग दौड़ कम, काम ज़्यादा। बाकी वॉलंटियर्स सारे लोग, चाहे वो MBBS के स्टूडेंट हैं, इनको बाद में, ये सारे लोगों को। फिर पीछे में राजीव, डॉक्टर मुकेश, डॉक्टर अमृतांशु, कुणाल, रोशन, नीतू, नीरज, पीछे भी हमारे कुछ वॉलंटियर्स हैं, सारे लोग। आप लोगों के बिना ये प्रोग्राम सफल नहीं हो सकता, जितने भी वॉलंटियर्स हैं। इसलिए कहते हैं कि वॉलंटियर्स ने बहुत मेहनत किया है तभी ये सक्सेसफुल हुआ है। अगर तुम लोगों के मेहनत नहीं किए होते तो शायद हम लोग कुछ नहीं कर पाते। वो यानी रीढ़ की हड्डी जिसको कॉन्फ्रेंस के कहते हैं, कोई क्यों बड़ाई करेगा आज कि हमारा एकोमोडेशन बहुत अच्छा रहा, हमारा फूड बहुत अच्छा रहा, हॉस्पिटलिटी बहुत अच्छा रहा। ये हमको नहीं कर रहा है, यानी ये तुम्हारे बलबूते पर इस कॉन्फ्रेंस को कर रहा है। अगर तुम ना होते तो ये ना होता। इसलिए हम इस बात को, कुछ भी पॉसिबल नहीं है विदाउट योर कंट्रीब्यूशन। एंड लास्टली, जो कम्युनिकेशन है, जो कल भी मैं अपने संभाषण में बात या सुबह बोला हूँ, याद नहीं है, शब्द बहुत इम्पॉर्टेंट होते हैं और शब्दों का एहसास बहुत इम्पॉर्टेंट होता है। जो शब्द बोलते हैं उसका एहसास। तो जो एंकरिंग कर रहे हैं, इनके बिना ये प्रोग्राम मास्टर ऑफ सेरेमनी कहे जाते हैं। क्यों? सबों के साथ अच्छे शब्दों के साथ लोगों को बुलाना, लोगों को बैठाना, लोगों को इज्जत के साथ कन्वे करना कि भाई आपका ये पेपर है, आप इसके चेयरमैन हैं। ये दोनों आई थिंक क्रेडिट गोज टू केशव, रिंकी, सुचित्रा एंड खुशबू। वेल प्लान्ड, कई दिन की कड़ी मेहनत के बाद इन लोगों का परफेक्शन आपने देखा। वी आर द थीम इज प्रेसिजन मेडिसिन। प्रेसिजन मतलब सही, सटीक, और इन लोगों ने सटीक किया। तो इसके लिए भी साधुवाद सबों को। और अंत में मैं भगवान का शुक्रगुजार हूँ जिसने इतने लोगों का सहयोग मिला, तब ये संभव हो सका। थैंक यू।
Thank you, everyone.
काम कर ही रहे हैं। रेखा देखो तो साजिद है, चलो तुम भी आओ।